Okay. 5, 4, 3, 2, 1. We all are live now. We can start the session.
So hello all, good evening all. So we are going to start fishbowl, PG fishbowl session and the master class, that is the preferred practice pattern on chemical injuries, cornea, retina and glaucoma. The PG fishbowl session is getting organized for the first time by Jharkhand Ophthalmological Society, and today is our second, third and the fourth episode. This is the brainchild of my dearest friend, Dr. Shweta Walia, and she has also agreed for being one of the moderator of the fishbowl session. So the fishbowl, a little bit about fishbowl. The fishbowl training method is a structured collaborative learning technique where a small group, that is the inner circle, that discusses a topic while a larger group, that is the outer circle, observes and takes note. It enables in-depth discussion, models active listening, and allows for large group participation without a chaos. It is effective for complex subjects, debates, and skill building. So there is a slight change in the program as some of our state Jharkhand's cornea faculties are in some other physical seminar in another city. So we are taking up master class on chemical injury and cornea first. Now we are going to do some customary introduction of the Jhos office bearers. And then after the master class of chemical injury and cornea, we will take up fishbowl in the same specialties, chemical injury and the cornea. So now I'm going to, because our lot of activities are related to the academic research committee. So I'm going to introduce our chairman, academic research, Professor Sunil. He is the HOD of Rio RIMS. Please share the slide. And the office bearers, of course, of the Jharkhand Ophthalmological Society. थोड़ा बड़ा करो भाई. Professor Sunil Kumar is Professor HOD, Rio RIMS Ranchi. He is the Medical Director, Government Eye Bank and Chief Cornea Services, Rio RIMS. He's done his MS Ophthalmology in PGI, Senior Residency PGI, and he has a teaching experience of more than 17 years. He has published more than 50 papers in national and international indexed journals, presented papers and faculty talks and instruction courses in various national and state conferences. He has many awards. To his credit, Best Paper Award, COS 2005, Best Poster Award, winner of the AIUS quiz, Dr. B.N. Gupta Endowment Equine Award, Isaac State Award, Distinguished Ophthalmic Teacher Award of India, late Dr. R. Singh Memorial Equine Innovation Award, Professor Sudhir Kumar Endowment Equine, so many equine awards. And he's the life member of AIOS, Equine, DOS, ISOC, Jhos, COS, and CSR. So now, I want, these are the office bearers of Jharkhand Ophthalmological Society. Dr. S.P. Chakanwal is the president, Jharkhand Ophthalmological Society. Sujay Samanta is the honorary secretary. Dr. Bharti Kashyap, myself, they have written wrongly. I am CSC Jhos, and Professor Sunil Kumar is ARC Jhos chairman. Dr. Malya Verma is honorary treasurer Jhos. So now over to Dr. Sunil Kumar for introduction of the moderators, Dr. Shweta Walia and Dr. Bharti Kashyap.
Yeah, so thank you, ma'am, and good evening, everyone. So I will introduce the moderator of the today's session. So
first share the slides. First share Shweta Walia's slide.
हाँ भेज दिए. बड़ा बड़ा करना, इतना छोटा क्यों कर रहे हो?
Please mute other one.
Premlata, please share the slides. First share the Shweta Walia's slide. Actually, yes.
Yeah. So Dr. Shweta Walia is the professor, MGM Medical College, Indore, and she is the chairperson, Scientific Committee, MP State Ophthalmic Society. She is also the chairperson, Scientific Committee, Women Ophthalmological Society. She is Central Zone Representative, OTSI, Central Zone Representative, IS, MICS, and she has to her credit more than 50 publications in national and international journals and contributed chapters in Hindi ophthalmology textbook. That is one of the initiatives in which Madhya Pradesh has taken national lead. And she has innovated technique of the sutureless, glueless SF IOL 2016. She has many awards like All India Talent Search Award by the then Prime Minister of India, Sri S.D. Devgoda, Best Teachers Award, and so many awards. So I welcome Professor Sweta Walia for to moderate the session. Yeah. So
Thank
thank you.
you, Dr. Sunil and Dr. Bharti for honoring. Thank
Yeah.
you so much.
Yeah.
Thank you so much.
So next moderator of the session is none other than Dr. Bharti Kashyap. So she is the founder director, Kashyap Memorial Eye Hospital, medical director, Kashyap Memorial Eye Bank, and she is specialized in the femto cataract and refractive surgery. She is chairman scientific committee of our Jhos, and she is also the chairperson of Women Doctors Wing IMA Jharkhand. She is secretary Women's Ophthalmological Society Jharkhand, and she is also the organizing secretary of our upcoming midterm conference of the All India Ophthalmological Society. And she has so many awards to her credit, and most important is that she has received the Nari Shakti Puruskar Award from the then Honorable President of India. So there are so many awards. So I welcome Dr. Bharti ma'am for moderating the sessions. Thank you. So
So it's enough. And now you please introduce our guest faculties.
yeah, sure ma'am. Yeah.
We are sharing the slides from here.
Okay.
First, Dr. Varsha, Dr. Sweta Walia is all done.
Yes. So good evening. So Dr. Varsha Bambani, she is the consultant cataract, cornea, and ocular surface services, Shankar Nethralaya, Chennai. See, the clinical and research interest include the dry disease, ocular chemical injuries, and Stevens-Johnson syndrome. She is the author of 15 plus publication in PubMed Index peer-reviewed journal, and she has contributed to 5 book chapters in ophthalmology. She is the regular faculty speaker and presenter at national and state ophthalmic conferences, and she is also the co-founder of the Ocular Surface Gurukul, which is an educational YouTube initiative dedicated to ocular surface disorder, featuring 50 plus academic videos. So welcome Dr. Varsha ma'am as a guest speaker and the expert of this session. So the next expert is again Dr. Professor Sweta Walia. We have already introduced. Next is the Dr. Nivita Narayanan. She is the Deputy Director, Accreditation, Safety and Quality Assurance. She is the Senior Consultant, Cornea and Refractive Services, Medical Research Foundation, Chennai. And she is passionate about the lamellar corneal surgery, cataract and refractive surgery. She has a strong commitment to advancing surgical excellence. She has actively participated in and conducted numerous surgical training programs and workshops, and she has presented clinical and research work at national and international conferences. She has published research in peer-reviewed scientific journals, and she is the recipient of the awards and recognition for excellence in the clinical work, research, and scientific presentation. So, welcome, Dr. Nivita ma'am, as an expert of these sessions.
Thank you. Thank you very
So,
much for the nice
yeah,
introduction.
the, the next expert is Dr. Charuta Purnik. She is the senior cornea consultant and founder director Ocular Generous Biotech Private Limited. She is a fellowship trained cornea and ocular surface specialist with expertise in the medical and surgical management of the ocular surface disease, corneal infection, keratoplasty, and complex cataract surgery. She is the founder director of the Ocular Generous Biotech Private Limited and serves as a senior cornea consultant at Medivision Eye Hospital, Hyderabad. And her advanced training includes the long-term cornea fellowship at LBP Eye Institutes and international training in ocular surface regeneration at the Kyoto University of the Medicine, Japan. And her clinical and academic work focuses on the interface of inflammation, infection, and immunosuppression with a strong emphasis on the antibiotic use,
Dr. Sunil.
early escalation. Yeah.
Dr. Sunil,
So
it's enough.
this is all.
So
Yeah.
it's enough. So and now we
Sure.
are beginning the exciting and the and academically rich enriching session on the preferred practice pattern in acute and chronic chemical injuries and cornea. And we are truly privileged to have with us with our eminent national faculties like Dr. Varsha, Dr. Shweta, Dr. Nivedita, Dr. Charuta, who bring immense expertise and experience in the field of chemical injuries and the cornea. So what makes this even more special is that they are also experts in our PG Fishbowl session on chemical injury and cornea session, and highly interactive and dynamic learning platform. So now I over to Dr. Sunil to quickly introduce the chairpersons, the one line introduction of the chairpersons who have joined. We have already shared with you the chairpersons of the master classes of the chemical injury and chemical
Okay, ma'am.
injury. Over to Dr. Sunil.
Okay, ma'am. Yeah, okay. Thank you, ma'am. So I will briefly introduce all the chairperson of this session. So first, none other than Dr. B.P. Kashyap. He is the organizing chairman of our forthcoming AIOS midterm conference, Ranchi, and is also the past president of the Jhos and ex-MC member AIOS. Next is Dr. Vibhuti Bhushan, is the vitreoretinal phacosurgeon and director of the Vishnu Netralaya, Jamshedpur. Dr. S.K. Mitra, again consultant ophthalmologist from the Jamshedpur. Dr. Rahul Prasad, additional professor, DO RIMS, Ranchi. Dr. Ajay Gupta, senior consultant at Rasmi Eye Care, Jamshedpur. Dr. Vandana, Ranchi-based senior ophthalmologist. Dr. Mayuri Bhattacharya, again senior consultant ophthalmologist, Ranchi. Dr. Dolly Tandon, senior consultant ophthalmologist at Ranchi. Dr. Pritish Parnay, senior consultant, Sadar Hospital, Ranchi. Dr. Abhishek Sinha, senior resident, Dhanbad Medical College. Dr. Ankit Gupta, oculoplastic surgeon from the Dhanbad. And Dr. Mohit Biskarma, senior resident at TMH Hospital, Jamshedpur. So I welcome all the chairperson of this master class on the chemical injury. So thank you.
Now over to Dr. Varsha Pambani for her didactic lecture. Please share your screen. Cornea वाला का कौन करेगा? Madam, please share your screen.
Yeah, ma'am. I'm just sharing my screen.
Yeah.
One second. Is my screen visible now?
Yes, yes.
Yes, very good.
So, very good evening, everyone. I am Dr. Varsha Pambani from Shankar Netralaya, Chennai. And I can continue.
Yes, ma'am, continue.
So, at the outset,
Dr. Bharti, please mute yourself because there are a lot of disturbances from there. Please go ahead, Dr. Varsha.
So at the outset, I would like to thank Dr. Bharti Kashyap ma'am for inviting me to deliver the guest lecture. And today my topic is surgical management of acute ocular chemical burns. In view of time, I would be presenting this with the help of some clinical case scenarios. So as we all know that ocular burns is a true ocular emergency, and the long-term visual rehabilitation actually depends on how well these are managed in the acute phase. The primary goals in essence are two. First is to remove the inciting agent and stop the ongoing insult that is happening to the ocular surface. And the second is to restore the ocular surface by promoting rapid epithelialization. And to do this, we have to address surface inflammation, intraocular pressure, ischemia, and exposure. So the most important thing in this is irrigation, the removal of the offending agent. The irrigation has to be immediate, it has to be copious, and ideally the irrigation has to be started at the site of the injury without even waiting for the patient to reach at the eye care hospital setup. Eversion of the lids and inspection of the furnaces is more important to identify and to remove any kind of residual chemical that is there. What is the choice irrigating solution? What is the choice of the solution? So these are the various irrigating solutions that are available, from tap water to balanced salt solution to ringal lactate, normal saline, diphoterine, and sideroth. What should be preferred? So the most effective irrigating solution actually depends on the pH and the buffering capacity of the solution. And diphoterine and sideroth are equivalent, followed by BSS, RL, NS, and tap water in that order. But what we should understand is that prompt irrigation is more important than choice of the irrigating fluid. So rather than waiting for an effective irrigating fluid, rather than tap water and on-site irrigation is more effective. How this is done? So minimum 30 minutes of wash which is what recommended. We should be doing it with 1 to 3 liters of irrigating fluid. We should ideally check the pH in the beginning and after that every 15 to 20 minutes. Also, we should check the pH 15 minutes after finishing the wash to be very sure that the pH that we are checking was of the eye and not of the irrigating fluid that we were using. And these are the prerequisites: a litmus test, a litmus paper, a irrigating solution, a kidney tray, and an IV set. That is all which is needed for a proper irrigation. Medical management, as we all know, involves broad spectrum antibiotics, cycloplegics, topical steroids, and I will not go into detail of this. Surgical management, it involves removal of the inciting agent, AMT or alloslet for promoting epithelialization, tenonplasty to address the ischemia, and tarsorrhaphy or skin graft to address the exposure. So skip this. Let us start with the cases. So this is case 1. This was a 34-year-old male who was a bystander for a carbide gun injury. On presentation, he came to us with the vision of 1/60 in the left eye. It was a grade 1 Jhos injury. As you can see over here that you can there are residual carbide particles, calcium carbide particles in the cornea as well as over in the conjunctiva on the left side over here, and a small central epithelial defect. So for this patient, we went ahead and did an EDTA chelation. And for the EDTA chelation, we took the patient up in the operation theater. As we took the patient up in the operation theater, we also did a amniotic membrane and onlay with the purse ring sutures. This is 6 weeks post-operatively, and you can see how clear the cornea is. This is 6 weeks and this is 6 months, and the patient vision improved to 6/7.5. This is a second case of a 17-year-old male who had a Chuna injury because of the blast at his workplace, and he presented to us with the vision of 6/18 in the right eye. The IOP was slightly on the lower side. The white 80 was 4. As you can see, there was a corneal defect with the surrounding conjunctival defect. These are the impacted Chuna particles over here, and in the fornix, ocular surface inflammation. So if we grade this injury, it is a Jhos grade 2 injury. What Jhos does not see is the amount of the tarsal defect, the pressure, the ischemia, and the exposure, which is covered in the new classification, that is an EPICS classification. And if by that we go, this is an E2, P0, I0, and X0, which is still a grade 2 injury. So for this patient, we went ahead with the debridement and a patch, that is an inlay AMT with the fibrin glue. And this is 2 months post-op, whereas best corrected visual acuity improved to 6/15. You can see that there is still a little bit of inflammation at this site, which had an impacted line. This is 9 months post-op and his vision improved. The corneal clarity also improved and the surface is now completely quiet. The third case is of an 18-year-old male, again carbide gun injury. He had undergone an AMT and a symblepharon release elsewhere. He was on topical steroids, glaucoma medications, atropine, antibiotic, Ocupil, and even oral oral steroid 6 milligrams TDS. On presentation, his vision in the right eye was hand movements and the finger tension was slightly on the softer side. So at that point of time, we had stopped his topical AGMs. This is the presenting picture. Now, if you see, there are still certain carbide particles which are fine carbide particles over here which are impacted in the cornea. Your corneal defect is very small, approximately 4/5, but if you carefully look, this is all conjunctival tissue. So this is a patient which has a significant limbal stem cell deficiency, as he had undergone amniotic membrane twice elsewhere. When we took him up for an EDTA chelation because still there were particles in the eye and with alloslit. This is post-operative picture, 2 months, wherein at this point of time, because of the significant corneal stromal haze, the uncorrected visual acuity was 1/16, but it was improving with the scleral lenses to 6/15. You can see how the eye is quiet. These are the slit bits that you can see on the cornea, and you can see that there is no defect and the surface is well epithelialized. And this is post 4 months, wherein his uncorrected visual acuity is 6/36, you can still see that these are some deep particles which are there, which over a period of time, what we have observed, remain inert and they do not actually perpetuate inflammation, and the eye remains quiet. You can see how the surface and the eye has quietened down over a period of time. This is another case. This is again a 34-year-old male who had an acid injury, accidental injury at home, and he had presented to us with a severe grade 6 duas. You can see there is total 360 degrees of limbal ischemia, corneal opacification over here, total corneal and surface defect. The finger tension was high. His vision was hand movements. So on EPICS, if we, on DUAs, it's a grade 6 injury, but what in addition to the grade 6, the EPICS classification tells us that it actually forces us to look at other factors like intraocular pressure, ischemia, and the exposure, which also need addressal in the acute phase management, and which actually have an indirect effect on promoting epithelialization of the surface. So as you can see, P+ denotes that the intraocular pressure was abnormal in this patient. It was on the higher side. So we had started the patient on topical AGMs. You can see that it is I2, which is a grade 2 ischemia, and then it shows that this needs attention and this needs probably some surgical management. And he also had a little bit of lag of ophthalmos and that is an exposure which is X1. So the surgical plan for this patient was tenonplasty, alloslet, and tarsography. I'll just share a short video of the surgery and the surgical steps. This is how we do the tenonplasty. We separate the good conjunctiva from the underlying tenons and from the underlying sclera. The dissection is done with the help of a scissors, and it should be deep into the fornix because the idea is to pull a vascularized pedicle over the ischemic part of the sclera. Now, this pedicle has to be thin. If the dissection is very bulky, then there is a tendency that it will retract back. The dissection also should be carried out deep into the fornices, as deep as possible, so that when we are pulling it near the limbus, it is free. This is secured in place with the help of a fibrin glue, and then it is anchored, augmented with anchoring sutures with 7O vicryl. Similarly, it was repeated on the superior side also, as it was a 360 ischemia. And this was followed by alloslet. Alloslet and not an AMT in this case because of the significant loss of the conjunctival epithelial cells. So AMT is a basement membrane. It does not have epithelial cells. So we have to supplement the surface for extra source of an epithelial cells for it to epithelialize faster. And this was followed by BCL and a tarsography. So this is post-operative. As you can see, 6 weeks at GA, you can see a completely epithelialized surface, no defect, a quiet eye. So here what we have done is it was a grade 6 injury, and with the surgical manifestation, the aim of the management is that all the E, P, I, and the X should come to 0. So here there is no defect. The pressure was controlled with Combigan, the ischemia was addressed with tenonplasty, and the exposure was addressed with the help of a tarsography. This is the pre-op, this is the 6 weeks, and this is the 6 months post-op. Again, another case of a grade 6 DUAS injury. Now, this was a young male who had a tuna thrown at him by one of his friends. And in this, again, this is grade 6. As you can see, there is an impacted lime over here, a complete 360-degree limbal ischemia, total surface defect. So the plan again was, along with doing a tenonplasty and alloslet, this also requires debridement or removal of a lime plug that is there, and in addition to that, a lamellar keratoplasty. So the pressing concerns are over here are the lime plug in the cornea that needs to come out, 360-degree of scleral ischemia that has to be addressed with the help of a tenonplasty, and 80% of the bulbar surface defect for which an alloslet was plant. There was also significant intraoperative scleral thinning, so we also did a scleral patch graft in this patient. This is a short video. A peripheral groove is made and layer by layer dissection of the cornea is done. You can see the line plaque coming out. We try to avoid a full thickness keratoplasty in these patients because the outcomes are not that great. So a lamellar keratoplasty is always preferred. And if you feel that there is some line which is still there on the desmids or the near desmids, you can always use an EDTA intraoperatively. Before using that, we can always use a litmus paper and check the pH. And if it's again on the alkaline side, then EDTA chelation can be done. This is the scleral patch graft that is done for the thinning, and the sutures over here involve the cornea and the patch graft, which was followed by the teninplasty superiorly and inferiorly. As you can see on inspection, this is a full line plaque that is still embedded in the conjunctiva and in the fornix. So this needs to come out. So a good intraoperative eversion of the lid and inspection is also mandatory. This is how we just go ahead and remove the line plaque because it's a fill. The chelation won't work here, so it has to be surgically debrided so that line conjunctiva with an embedded line is separated from the underlying healthy tenons tissue over here. And this is followed by the alluslet. So the AMT was covering fornix from the superior fornix to the inferior fornix through and through, and the slet bits were put on the cornea as well as on the perilimbal conjunctival area also. So this is 2 months post-operatively. This was his pre-operative, you can see, and this is the post-operative picture. Well epithelialized surface, a quiet eye, and a salvaged globe. This is my last case, which is very special to me. She was a 12-year-old female who presented with a firecracker injury, very uncooperative. She did not allow any kind of examination in the OPD. So we took her up for an examination plus minus additional procedures in the operation theater under general examination. And as you can see, she had a significant periocular burns as well. The right eye was a little better eye and only had a small defect, which just resolved with the help of the topical medical management. But the left eye had significant injury. You can see this is the ischemia had a corneal defect. Almost a little bit of limbus superiorly was saved. You have the soot particles on eversion over here, as you can see, and you can see this is all tarsal ischemia also. So this was a grade 4 duas and an EPICS, which allows us to grade the conjunctival, the corneal, and the tarsal defects, the pressures, the ischemia, and the exposure. So the patient was planned for a soot removal, a sectoral teninplasty, and an amniotic membrane. This is how the intraoperative picture looks like after the teninplasty and the AMT. And to take care of the periocular burns, every day the Bactigras dressing was done and the patient was co-managed with the help of our oculoplasty colleagues. So it is very important that these patients need to be managed across multi-specialities. This is how this is post-operative 3 weeks. Superiorly, we can see it is well epithelized and the retained matter, even the blood vessels have started coming in over here also, but there is a little bit of an area which is still ischemic. So we took her up again for a revision teninplasty, and this is how 4 months later you can see it's a well epithelized surface, clear cornea, a little bit of a focal limbal stem cell deficiency, which you can still see on the fluorescent stain, but otherwise the vision improved to 6/9, and here you can see the periocular burns also have been managed very well. So this is our channel Ocular Surface Gurukul, which has all the videos and many more videos, academic videos. You can log into it and you can see. Thank you so much. This is our team at Shankar Netralaya, myself, Dr. Shweta, and Dr. Mukundan. I'd like to take an opportunity to announce that we are hosting at Shankar Netralaya Ocular Surface and Keratoprosthesis Conference, which is in July 23, 24, and 25 next year, not this year, that is in 2027. And It's the theme of the this year's conference is One Surface, Many Disciplines, taking the patient through many specialties. I invite and welcome all of you, whoever are interested. You can contact me. The website will go online in few months, and I welcome you all to join us in this ocular surface specialty conference. Thank you so much.
A very nice representation of your surface team, and I really respect the team. So thank you so much. So you have to stay connected because you are there in the fishbowl chemical injury also. Over to Dr. Shweta Walia for the chronic chemical injury management. Please share your slides. Yes.
Thank you, Dr. Bharti, for giving me this opportunity to present on ocular chemical burns, complications, and sequelae. Though the topic has been very well covered by Dr. Nivedita, and it was like, though they were doing acute management, they have to follow the patient long term because the patient needs multiple interventions so that we can give a wonderful outcome to the patient. So you can see over here that this is a patient who had a pneumonia injury, industrial injury, and day 14, it was grade 6. And though he survived the acute phase, but in 3 months, we were still facing the sequelae. There was ischemia, there was corneal opacity, and vision was less, and the patient needs a sequential management. So what is the biggest challenge in chemical burn sequelae? It is persistent epithelial defect. There is limbal stem cell deficiency, corneal melting, corneal scars. There can be symblepharon, there can be entropions. There is intractable dry eye, and most commonly and the unneglected one is the secondary glaucoma. So this is a patient who had persistent epithelial defect with limbal ischemia at 3 months. And the main aim was to halt melting and epithelize the surface. So what do we need to do? We need to be aggressive in lubrication, give preservative lubricants to the patients. We can also give autologous serum to the patient, and we usually give 50% autologous serum to the patient, and it has wonderful effects. We can also go for amniotic membrane grafting and combine it with a slit. We can go for tarsorrhaphy, and scleral lenses is one of the things that is gives wonderful results in such patients. It gives a normal equilibrium to the cornea and heal. So the pros lenses, that is the prosthetic results, though cost is a big issue. In India, they cost about 35,000 to 45,000 per lens. The diameter of these lenses is 15.5 to 18.5 millimeter diameter. It also prevents rubbing of the lids onto the cornea and provides a normal equilibrium to the cornea to heal. So how do you diagnose limbal stem cell deficiency? In early phase, acute phase, it is very easy to diagnose it. But in late phase, how do you see it? So this is the normal healthy limbus. You can see the Voigt's palisades over here at the limbus. And in end stage, there will be loss of these palisades. There will be conjunctivalization of cornea. And when you do fluorescein stain, you will see a typical fluorescein whirl on the cornea. So how do you manage such patient? The step 1 is conservative management with preservative-free lubricants. If it is mild or partial limbal stem cell deficiency, autologous serum, as we discussed, is a wonderful option. We can proceed to stem cell grafting. If it's a unilateral total stem cell deficiency, slit or cultivated limbal stem cell transplant or CLAW, that is conjunctival limbal autograft, gives wonderful results. But if it's a bilateral total stem cell deficiency, you have to go for keratolimbal allograft or a cultivated mucosal epithelial transplant, but these require systemic immunosuppression. So before we proceed to anything, we need to fix the environment. So what do you need to do? You need to do the adnexal correction. In this patient, you can see extensive symblepharon with ectropion. So you need to release this symblepharon, reconstruct the fornix, and if it is entropion, you need to correct the entropion and also take care of the tracheasis. So if the adnexa is not corrected before, all our attempts to epithelize the cornea and prevent limbal stem cell deficiency all goes to waste if adnexal is not corrected. This is another case of a patient with large ptosis, and we did tarsal rotation for this patient and corrected the large ptosis. The another problem in sequelae is that the cornea is opaque. So in this patient, what will you do? Whether will you observe for to give a ocular surface reconstruction, or you will go directly to the penetrating keratoplasty. So the idea in these patients who are having limbal stem cell deficiency, first is to go for stem cell transplant. So this patient I showed you earlier, this was having a persistent epithelial defect with a limbal stem cell deficiency, and we managed it with a amniotic membrane grafting with a slit, and you can see that after 6 months of follow-up, the cornea had begun to clear out. So we had developed our new technique of doing
LDP. Here I like a technique of modified post-switching technique, in which we put multiple chains, each type of sutures. And the only care that you need to take is when the second pass to begin slightly behind the first one. And in the end, you open up all the loops, and as you form the suture, all the suture is buried underneath. Let's see in the patient's eye. So we start to do chain stitch, taking care that the next pass is just starts behind the first pass. And in the end, we open up all the loops. As you pull the suture, the entire suture goes underneath the amniotic membrane. And if you see how snugly amniotic membrane is fitting onto the patient's cornea, just like you have used glue. So this is the second case. You can see chain stitch.
This is our modified technique of doing suturing in amniotic membrane, and it gives results similar to the glue. Whenever we are deficient of glue, we do suturing in this technique. So now, as I told earlier, that if you do grafting, keratoplasty in a hostile environment, the ultimate result is epithelial breakdown, stromal melt, deep vascularization, and an aggressive rejection. So you first need to stabilize the ocular surface and then proceed for a keratoplasty. So this is our patient of chemical injury in which there was extensive corneal opacity, and we went for a slit. And after 3 months, you can see the central cornea has begun to clear. And for this patient, we actually didn't require to do penetrating keratoplasty. And we have found over years that in such patients, slit had reduced our need to go for penetrating keratoplasty. For other remaining patients who are having end-stage disease, and the only ultimate treatment is keratoprosthesis. Though we are not doing keratoprosthesis, we are referring the patients for keratoprosthesis. So first thing is to do adnexal and eyelid stability, do tear film restoration, then go for stem cell restoration. If there is corneal opacity, proceed for DALK or penetrating keratoplasty, and finally visual rehabilitation. The only thing that is missed many times is the glaucoma, which is responsible for delayed healing in 22% of the cases. And this must be kept in mind whenever we are dealing with the chemical injury patients. And when the vision, nothing works, no PLIs, evisceration with orbital implants gives wonderful results. And this is one of our patients who had no PL. And we did evisceration with implant, and you can see the outcome and the happy patient. So what top 5 mistakes we should avoid is grafting before stabilization of the ocular surface and stem cells, missing subtle peripheral signs of limbal stem cell deficiency, ignoring minor symblephrons and entropion that can cause mechanical friction, undertreating severe toxic dry eye environment, and delayed referral to a tertiary ocular surface centers. If you feel you are not going to able to manage the patient, better refer it to a higher center so that he gives a good rehabilitation. This is the patient of one of our patient, Mukesh, and after 2 years, he has some amount of vision so that he can do his routine work. So the success of chemical burn patient is not measured by the healing of the burn, but the restoration of the stable ocular surface. And I had done my PhD in ocular chemical burn, and it started in 2019, and because of COVID got delayed, and this year only, I got my degree in PhD in ocular chemical burn. Thank you so much for listening to me. Thank you, Dr. Bharti.
Thank you so much. Thank you so much. Please stay connected. And now, before we start the cornea session, so I would like to quickly introduce Dr. Sunil to quickly introduce the chairpersons of the cornea session.
One question, please, if I can ask to
Yes,
Dr.
yes.
Yes, ma'am, please.
Dr. Shweta. Very nice presentation, Dr. Shweta. And the amniotic membrane graft. When do you normally, what is the time which is taken when we do the amniotic membrane grafting? Normally, how much time does it take when we do it?
So if you find that the cornea is not starting to heal in 7 to 10 days, then in acute phase also we have started doing amniotic membrane graft, and with wonderful results.
As early as possible, within a week results.
Correct.
And where do we get autologous serum eye drops?
So we in our hospital, I'm in medical college, and over there we are using autologous serum for past since 2004 we are using it, and actually it has gone into our practice only. Whenever we see that we are not getting results with the artificial tears, we take blood sample of the patient, send it to the pathology department, they centrifuge it, take the serum, and they send it to us, and we dilute it to 50%, and we ask the patient to keep those drops in refrigerator or in a cold environment, and we give multiple bottles to them. One bottle is kept out and rest of them is kept in refrigerator, and we usually dilute it with artificial tears only. We don't dilute it with normal saline.
Means that 10 ml, if they give you 10 ml of serum, you dilute it with 10 ml of artificial tear.
Yes, ma'am. Yes, ma'am.
So what artificial tear you use for the dilution? Which one?
Yes, artificial. Normal carboxymethyl cellulose.
Okay.
Okay.
So any question for the acute injury for Dr. Varsha? So we can take up the questions later also. So over to Dr. Sunil for the quick introduction of the chairpersons of the cornea session, because we are going to take the master class of the cornea after this.
Okay, ma'am. So after the excellent session on the chemical injury, now I will introduce the chairperson of the master class of the cornea. So first Dr. Sunil Kumar, myself, then Dr. Bharti Sharma, she is the HOD of ophthalmology at TMH Hospital, Jamshedpur. Dr. Seema Kumari, she is Associate Professor, MGM Medical College, Jamshedpur. Dr. Nidhi Kashyap, Senior Consultant, Cornea Services at Kashyap Memorial Eye Hospital, Ranchi. Dr. Pooja Kumari, again from the TMH, Jamshedpur. Dr. Vishal Kumar, Consultant, Kashyap Memorial Eye Hospital. Dr. Nitish Bhardwaj, Cornea Consultant at Sardha Hospital, Jamshedpur. Dr. Mohit Viskarma, Senior Resident at TMH Hospital, Jamshedpur. Dr. Seema Singh, Senior Resident at Rio Rims, Ranchi. Dr. Dipankar, Senior Resident, Rio Rims, Ranchi. And Dr. Smriti Chaudhary, again Senior Resident from Rio Rims. So I welcome all the chairperson for this master class on the cornea session. So thank you.
And I hope all the senior residents, they have joined. So we have called each one of them. So now over to Dr. Nivedita Narayana. Dr. Nivedita, can you please share your slide?
Yes, ma'am. You are able to see my slides?
Yes, you are audible and visible both.
My slides are visible?
Yes, madam.
Okay.
Yes, visible.
Okay. Okay. So I'm just going to talk about pearls in therapeutic penetrating keratoplasty. I'm Dr. Nivedita from Shankar Nethralaya. And this is a very basic thing for any postgraduate when they enter into the subject of cornea. So the primary goal here is to eradicate the infection, preserve the globe integrity. it is only secondary that we look at the graft clarity and the visual outcome. We have some preoperative important things that we look at. One, first and foremost, is infection control. To achieve this, we have to look at the causative organism and go for maximum targeted antimicrobial medication. If in spite of all this, the infection is progressive, then we look for an appropriate surgical timing. If the cornea melts in the due course, if there is an impending or frank perforation, it is again an indication for surgery. When we plan for surgery, look at the involvement of limbus, sclera, anterior chamber. In anterior chamber, we have hypopyon. We should know that hypopyon in a bacterial infection is only inflammatory, whereas in fungal infection, it is infective. So that should be taken into account. Lens involvement. If it is an injury-incited infection, we have to look at the integrity of the capsule because accordingly we'll have to plan the surgery. Whenever the posterior segment is not visible, ultrasound biomicroscopy is important to look at the status of the posterior segment. In our setup, we have the liberty of retinal colleagues who will join us when we venture into the therapeutic grafting. Now, once all of these is done, procuring donor cornea, we need not wait for an optical grade of the cornea. Even at therapeutic grade is good enough because if you remember the goal, it is eradication of infection and integrity. So the faster we do, the better it is. In case of larger graft, it is important to look at the donor corneal rim, whether it has sufficient scleral proportion. Now, coming to the intraoperative pearls. Triphoning. Before we go into triphoning, we need to stabilize the globe because these eyes are often very different and you are in for many surprises. So Fleringa should be used in all the therapeutic grafts. Next is the most important thing is the sizing. Sizing of the host triphonation. There should be a healthy 0.5 to 1 millimeter of clear margin beyond the infected area of the cornea. And then when we plan for the donor cornea, you'll have to be oversizing the graft, like usually 0.5. If it is a collapsed globe or a soft eye or a perforated cornea, you can even oversize it by 1 millimeter. At the stage of open sky, it is important to inspect, excise all the necrotic tissue, inflammatory membrane, clear the hypopyon, and all material possible should be sent for micro and histopathology investigation. Touching the lens is avoided as much as possible while removing the synecholysis. Vitrectomy also should be done only when it is indicated. Now look at this case. This has a clear lens, limbus to limbus involved cornea. I have done a large corneoscleral graft. I have not touched the lens. The patient post-operatively with reasonable clear graft is still seeing well. It's a young patient, so you don't want to touch the lens. Now, when the patient is coming for later with an cataractus, you can go for an optical graft with lens management, but definitely not when the eye is infected and inflamed. Why? Because you want to avoid positive pressure-induced PC ruptures, which is very common in the open sky stage and leading to vitrectomy. So an anterior segment infection will be easily spread into the posterior segment, which as a surgeon, we should avoid. Next is the suturing. We should use only interrupted sutures with tenonylon. The tightening should be just watertight, not very tight, because very often these eyes can be very soft and you don't want to, inflamed tissue should not be crumpled with your very tight sutures. One important thing is definitely do 2 PIs. One, in case one is blocked, at least the second PI will start functioning because inflamed eye often form heme and fibrin which can clog them. And knot should be buried in the donor side. Post-operatively, all patients should continue their respective antimicrobial treatment. Once the microbiological histopathological reports come, the treatment can be tailor-fit. If the patient is improving, then you can wean off the medication. Usage of steroid. It should be avoided in the active infection state and when the graft has epithelial defect. Now look at this graft. It's a total epithelial defect. No steroid at this stage, even if you have used a good optical grade eye, because we don't want recurrence of infection and graft melt. Now, in fungal infection, it is definitely contraindicated unless we are sure that the infection is completely mitigated. And then when we start using steroid, you have to be very careful. This is a small tabular column which tells when to use what. Systemic antimicrobials, definitely post-op up to 2 weeks. In case of fungal, it is longer. In case of viral, it is much longer. Topical antimicrobials, until the epithelial healing, it should be in maximum dose. And then until the infection is eradicated, definitely some kind of antimicrobial should go on. In acanthamoeba case, it has to continue for months because we all know that acanthamoeba forms cysts. The cysts are not amenable to medication. And over a period of time, when the cyst ruptures, if you're not on topical medication, you are going to have a recurrence. In viral, topicals are not so important. Until the epithelial lesions are healed, you can continue the topicals. Afterwards, it's mainly systemic. Topical steroids, epithelial defect is healed. Then under antibacterial cover, in bacterial cases, you can use steroids. It should be withheld in fungal, as I told you. In viral, no role of that when the epithelial lesions are present. In acanthamoeba, for severe uveitis, you need to start a topical steroid. Systemic steroids are reserved for severe cases in general, and in acanthamoeba when there is a scleral involvement. Cycloplegics for ciliary spasm and preventing synechiae due to posterior anterior uveitis is as usual. Tear substitutes facilitate healing, so it should be used immediately post-operatively. Anti-glaucoma medication as and when required. It is important to look at the pressure post-surgery. Avoid pilocarpine and prostaglandins. So when you look at the monitoring of the patient, you'll have to look at the graft-host junction and recurrence of hypopyon. These are the two early signs where the recurrence will be. Complications, we have already told you how it is. So looking at the theoretical part is one. Now let us look at the case. This is a young child with a fungal keratitis, injury-related infection, and the eye was little soft. Chamber was not so fully formed. So along with antimicrobials, I gave cyanoacrylate glue with bandage contact lenses. Patient was started on dual antifungals and systemic. Did not improve, so we had to do a therapeutic PK. Post-operatively, though there was no recurrence of infection, because of the long duration of closed chamber, patient developed synechiae and pressure was spiked. So we had to do a tube AGV. In children, it is very difficult to release the synechiae, it reforms, and so this patient had to have an AGV. Now let us look at a second case. This is an acanthamoeba keratitis patient who came with very good vision and only a ring infiltrate. But you can see that it is long duration because the limbus to the ring area is not very clear. So we explained to the patient that it is a severe case. You need a large graft. She was not willing and the lens was also clear. She was lost. She came back 3 months later like this with a total white cataract and vision is dropped. So she has come back and her infiltrate has also worsened. So now she understands it has to be continued. Along with the medication, she was willing for surgery. I did only a large therapeutic graft. I did not touch the lens, though it is a total cataract. Once the infection was completely gone, around 6 months she was on medication. Once everything was complete, she underwent optical PK with ECC IOL. Her vision recovered. But because of the long duration and the severity of the infection, her epithelial healing was bad. She eventually developed PED and the graft was failing. I did an AMT and the eye became quiet, waited for some time, and then she underwent a second optical PK. This is the third PK in her. And with this, I also put an AMT, which is kicking well till now, and she's having a reasonable vision. So though we have a standard protocol, each patient teaches how to titrate the medication, how to change as the patient's flow changes, we'll have to intervene or withhold the treatment. So in conclusion, large trephination for the to encompass a clear zone beyond the infiltrate is important. Excise all the infected tissue with clear margins. Donor graft usually should be oversized by at least 0.5 up to 1 millimeter. Send the material for microbiological and histopathological investigation. Continue post-operative antimicrobial treatment until the infection is mitigated. Use of steroids should be cautious, and in fungal cases, definitely you have to withhold for some time. So the goal is save the eye first, vision later. My references, thank you.
Very nice paper. I must appreciate that you have covered almost everything. I wonder, what do you do? You know, in Jharkhand and this area, we have very less amount of cornea that is available. So, what is your experience about the glycerin preserved cornea for the therapeutic keratoplasty?
Fortunately for us, we have good supply of cornea. We have also got a tie-up with the Sight Life. But during the COVID time, we did face the dearth of corneal tissues. At that time, we used glycerol preserved cornea. It does do a good therapeutic effect, but then it will not give you the optical grade corneas. And one important thing when I started using, what I understood is these glycerol preserved cornea for some reason are very easy to have decimate separations. So I even have a publication where I spoke about reverse suturing. Like we go 90% depth. In these cases, I took a reverse suturing anchoring the decimates. So once in the early COVID periods, when we had more and more grafts with decimate separation, we took the reverse suturing so as to retain the decimates. So that is one lesson which we learned. But glycerol preserved eye is a doable project in case of dearth of donor corneas.
Yeah, very nice. My input would be, if you're using a glycerin preserved cornea, because we don't have so much of cornea, optical type. So what we do is preserve them. We use it even after 6 months or 7 months also. We take out the cornea and keep it in the saline for some time. Then the cornea becomes it softens, and the transparent cornea, which is glycerin preserved, becomes opaque, and it absorbs fluid. So you have to be very, very careful when you're taking the bites. Correct. And you very correctly said, to keep the decimal tumor attached, we can take all the reverse. And it is easier to do a continuous suturing rather than interrupted ones. Of course, when you're doing continuous sutures, you can give interrupted in between also. That helps. A very nice paper, very nice one.
Yeah, thank you.
So now to our next cornea speaker, Dr. Charuta Purani. The topic is every cell counts, the life journey of an endothelial graft from donor cornea to decades of clarity. Over to Dr. Charuta. We have already done your introduction, Dr. Charuta. Dr. Charuta, you are muted. Dr. Charuta, please unmute yourself. Dr. Charuta, you are not audible.
Please call her. Please call him. Please call.
Okay.
Hello, good evening everyone.
Yes.
Is my screen visible?
No, your screen is not visible yet.
Please share your screen.
Yes, ma'am. From here, I'm sharing.
Yeah, now it is
Yeah,
visible.
now it has come. Now it has come.
Please put in the slideshow mode. Yeah. Slideshow mode.
Slideshow mode. Please go to the slideshow mode.
So, good evening, everyone. Today, I'm going to talk about a different topic. So, apart from the usual surgical steps and the tips, this is the journey of a graft, how it reaches the patient. Ma'am, am I audible?
Yeah, just double click the center. It will be full screen. Just double click. It will be full screen.
Mohit.
Is it okay now?
No. उसी को edit की हो ना.
You have to put it. Yeah, that's better. Yeah, yeah.
Now it has come. Now it has come.
How?
So today, am I audible and the slides are good?
Yeah, yeah.
Yes, yes. Please go on.
So this is the journey of an endothelial graft, and I'm going to talk very different from what the surgical steps are going to be. So we've been working on this from the last 6 years, and if we think about it, most surgeons would say that the graft survival actually begins maybe at donor selection, tissue preparation, or at the time of surgery. But actually, truly, it begins the moment that the donor passes away. And graft longevity, what we have realized, is a continuum and not a single operation. So if we see that the donor, after that the retrieval, its preservation, preparation are equally important as the next steps of recipient selection, surgery, post-op care, etc. Of course, all these steps are also important. Now we need to understand that the endothelial reserve is a finite amount of reserve, and that because the endothelial cells don't multiply and are stuck in the G0 phase, they don't really regenerate in vivo. And there is a process of progressive loss even when we are living, and which continues when the graft is transplanted. So donor factors that we need to understand include the age, the baseline endothelial reserve of the donor himself, the prior ocular surgeries, how much time was lost between death and preservation. The eye band technique also is very important. The person who is retrieving must have very good technique. The storage, medium quality, transportation, logistics, etc. are also very important. Now, next would come the preparation of the graft itself. So, when do cells disappear? Trephination, peeling of it, the scroll formation, the staining, loading, dyeing, all these injections, all these steps will lead to loss of some of the cells. Now, micro trauma at every step will add before the graft ever enters the eye. And we need to understand that equally important as manipulation is the endothelial actual attrition. So, although older donors will unfold very beautifully and nicely, they already have a very low reserve. And diabetic donors, in addition, we have found even practically, and it has been proved by various studies, that they peel poorly and they peel unpredictably. Now, repeated staining again is not very good for the grafts. Touch points should be minimum when we are manipulating the graft, and the orientation must be maintained as best as possible in the right manner from the beginning. Now, Fuchs endothelial dystrophy, uncomplicated pseudophakic bullous keratopathy are sort of a little bit low risk for a hostile environment. However, pseudophakic bullous keratopathy most often happens in complicated eyes that have had an eventful cataract surgery. Many a times we find vitreous which is present, vitreous tags that are there, or remnant.
Dr. Charuta, I'm sorry for disturbing you. Could you please put this slide in the full screen mode? Yeah, and put it in the full screen mode. Put it in the slide so it will come to full screen mode. or else this is better than last time.
Are you seeing the presenter view?
You have not put it in the full slide mode. You have a
Actually, I'm just sharing my whole screen, but I'm not sure what you are seeing.
What we're seeing is the present slide and the slide which is going to come.
Ma'am, you'll have to put it in the slideshow mode. It's downstairs. I mean, in the lower corner.
It is in that mode only. Now is it fine now? Okay, now to select.
Slideshow mode.
The presentation is not yet shared.
Oh, lovely. That's the one. Yeah.
So now, low risk, yeah. So now uncomplicated PBKs are generally very rare to find. Most often the cataract surgery has been eventful and we see cortical matter, vitreous tags or lens dislocations, etc. And then we have to correct those. So again, that kind of a hostile environment is not very great. Any previous vitrectomy, previous glaucoma surgery again leads to a rapid endothelial cell loss. And other risks include uveitis or a previous failed graft wherein the inflammation factor is very high. Ocular surface disease also surprisingly does contribute to a prolonged inflammation, and any anterior segment reconstruction or tubes, shunts, etc. will also lead to a hostile environment. So this is a checklist. We need to look at the ocular surface, rule out meibomitis, look at the glaucoma status, whether the IOP is controlled or not, and the iris defects if there is a sector iridectomy that is present. Look at vitreous support, whether there are tags that are present, any synechia that are present that need to be broken. So all these manipulations are preferably done 6 weeks to 3 months before any endothelial keratoplasty, so that the inflammation post these surgeries has come down a lot. And next thing is the lens status, the pseudophakia, whether it's an appropriate lens. If it's a one-piece lens in the sulcus, then obviously it's going to cause a recurrent release of pigments and going to reduce the graft longevity. Look at the compliance capacity of the patient, the fellow eye, whether it is having a similar outcome. Now, intraoperative enemies are also mechanical. For example, if the size of the incision is very small, or if you have to repeatedly inject, repeatedly unfold, lot of manipulation, contact injuries happening, such as that happens in juniors when we are novices. Fluidics, again, chamber instability. If we've not put the right support, if we've not used fluidics properly, if the AC is collapsing a lot, if the person who is assisting us with the AC control of the AC chamber depth maintenance is not used to our way of operating, unstable AC depth, as I said. And then there is also if you have excessive pressure, if you're leaving the bubble for too long, that also adds to the insult. So all these factors are to be taken care of. Now, before insertion, if you have planned every step, you have your backup instruments, especially for iris manipulations or for the graft manipulation. If you've minimized the endothelial contact, your AC is appropriate depth, you've kept the chamber stable, you have an AC flow maintained, your maneuvers are gentle and you're mindfully doing every step, then the flow is very smooth and the unfurling is also least traumatic. If we underfill, then it's going to lead to a post-operative detachment and rebubbling. And if you overfill, you might get pupillary block and raised IOP spikes. And again, that will also lead to a endothelial cell injury. So every second intervention is going to lead to further loss, inflammation, further and earlier failure. Post-operatively also use the steroids based on the inflammation level of the patient. Don't have a use the same procedure, the same timetable for every patient. Monitor and taper and increase or decrease as per the previous inflammation and also what you expect. Heavily pigmented irides or excessive manipulation, you can prolong the steroids and taper more slowly. Of course, IOP surveillance is also equally important. educate the patient twice, thrice, 4 times or every visit regarding rejection, optimize the surface, and make sure that the patient understands the need for follow-up discipline. Of course, we know with every rejection we'll use a large number of cells. Every rejection will accelerate the life of the cell, and it's going to eventually the cells are going to die. So glaucoma is one of the most common cause, chronic attrition. Also, we know that the graft cells, the cells of the endothelium drop very fast as the graft is implanted in another eye. Add to this, if the preoperatively the patient has had something like a viral keratitis or a reason for repeated inflammations, then also the graft is going to die fast. Now, this is the a simple advice that a very good friend of mine gave me, and she said that like in any relationship you have deposits and you have withdrawals. If your withdrawals are going to exceed your deposits, then the relationship is going to fail. And this is these are the factors which healthy donor tissue, proper preservation technique, gentle surgery, controlled inflammation, good IOP control, etc. are going to help in a larger bank deposit. And the more you withdraw, the faster it's going to fail. Now, this is something that we have done in collaboration with the Kammam Eye Bank, and I want to stress on this because this is something new and this is something which is very close to my heart. So we know that a lot of our population is now live longer, they live healthier lives, and a lot of our donors are 80 plus. So can we really truly utilize these tissues, or are they going to end up in somebody's training center or in glycerol? Now, what we have been trying to do is that we know that they are underutilized because older age, obviously the cell counts are low, and then many a times accelerated cell decline happens during the storage, and guttata are also more commonly seen in these age groups. These also lead to rejection of the tissue to be used for optical grade. Now, ROCK inhibitors have shown promise in endothelial cell survival, and we've been trying to maximize elderly cornea viability by using these ROCK inhibitors and other special techniques. So what we've done is all these 80 plus tissues, we've done the biomarker profiling, and we are doing specular and confocal analysis. The experiments are ongoing regarding ROCK inhibitor supplementation, harvesting technique improvisation, and just to see whether the transplant outcomes are improved or not. Now, reconditioning of the epithelium, we know that ROCK inhibitors promote CEC survival in the laboratories, and they prevent reverse the contact inhibition, which prevents CEC regeneration. Therefore, they have allowed the cells to regenerate. Now, these are the first set of experiments that we did in the bovine cornea, and we injected viscoelastic device at the time of harvesting the corneoscleral rim from the whole globe. And in these we showed that definitely injection of a viscoelastic device led to the formation of less number of dead cell area. So if you can see the first image wherein no injection was used, the area of dead cells is much larger as compared to when viscoelastic device was injected. Now, interestingly, both the HPMC injection and hyaluronic acid injection led to almost similar amounts of endothelial cell loss, and if you can see, the average area staining positive is almost equal in both, and there is no statistically significant difference between these two. So however, these two groups, that is no injection versus the with injection group, showed a significant difference in the number of dead cells that we found. So preconditioning with intracameral or viscoelastic devices improves the endothelial clarity, is what we showed in 138 fresh bovine eyes. Now back to the human cornea, we've done this study is now ongoing, and we have found similar results even in the human cells. All tissues which are not of optical grade above the age of 75 or 80, we have included in the study, and we find that the mechanical buffering and metabolic stabilization leads to better clarity of the graft. And this hyaluronic acid chondroitin sulfate is also having as encouraging results as the inclusion of ROCK inhibitor in the storage technique. So this is the conceptual innovation that we have, that mechanical buffering reduces the stress, maintains integral structural integrity, metabolic stabilization improves cell viability, and improved optical quality leads to an increased and extended cell survival. So the globe, once we receive a globe, the reduced stress itself because of the maintained structural integrity helps us in improving the cell longevity. So recommendations, what we aim to do is that interested eye banks or those who want to now partner with us, we want to replicate this the scale of this in other eye banks as well and help improve the utilization of these tissues. So we've started a multi-centric study a couple of years ago, and we've recruited 3 eye banks in the same, and hopefully as the graft outcomes come in, we will have more robust data to show regarding the eventual graft survival as well. So of course the laboratory assistance that we have received is also ongoing, and then there will be live dead cell assay data which we have, which is ongoing, and that will be able to give us more data on what we have achieved with this with these modifications. So the other things that we want to include in our research is also AI assisted specular analysis, so that we know that many a times the cells look very healthy, the cornea is functioning very well, but the cell count itself is very poor. And other things include remote telemedicine linked slit lamp photography, and use of all dark tissues for use of all low endothelial cell count for darks, and if we can have dynamic preservation to allow active nutrient delivery to the corneas. So we know now, coming back to the first thing, we are not merely transplanting the corneas, we are custodians of this population of cells, and we need to improve the longevity, because the most common indication apart from infections and dystrophies for a graft is a regraft. So we need to make sure that each graft lasts as long as we can.
It was a very nice presentation. The people who are talking about the penetrating keratoplasty, what I feel that one of the most common cause of failure of the graft is high intraocular pressure, and you get a lot of peripheral antidysphagia. So nobody's talked about the PI. Do you do PI in such cases, especially the PK, and especially when you are working in a relatively inflamed eye, you have to do therapeutic keratoplasty. What is your take about PI?
100%, sir. Every inflamed eye needs at least one peripheral iridectomy surgically. Sometimes in an inflamed eye, wherein say it's a fungal infection or a very fulminant infection, and I'm doing a therapeutic, I do 2 also, because sometimes the inflammatory membrane blocks one. So
yes.
But in routine penetrating keratoplasty, optical ones, where we don't have any nuclear sclerosis, the lens is clear, in those cases I avoid, but I keep a close observation. Or if it is pseudophakic, then there is no question.
So you mean inflamed eyes you do
yes.
to PBHI in the for therapeutic keratoplasty, but optical you don't do.
Optical, if it is a clear lens, if it is a cataractous lens, then yes. If it is a pseudophakia, then no. Then it's not required.
Good.
Okay. So we have completed the master classes, the preferred practice patterns of cornea and chemical injuries, and now we are going to start our second, third, and the fourth Jhos PG fishbowl session by the Jharkhand Ophthalmological Society. And I'm very confident that this focus priming on chemical injury and cornea will not only strengthen the fundamentals of our postgraduate students, but also empower them to actively engage, think critically, and derive maximum benefit from the upcoming fishbowl session. So now I invite Dr. Bharti Sharma. She is the head of the cornea services of Manipal TM Tata Main Hospital, Jamshedpur, for a quick introduction of postgraduate students, the inner circle and the outer circle. So over to Dr. Bharti Sharma, madam.
Yeah, thank you, ma'am. So, welcome everyone for this fishbowl session on chemical injury. So, quick introduction. We have a lot of postgraduate students with us today. And from the inner circle, we have Dr. Sonia Ghosh, Dr. Shrishti Shreya. They are both from Rio Rims, Ranchi. From MGM Medical College, Jamshedpur, we have Dr. Amar Kumar, Dr. Mayank Saran, Dr. Vikas Thakur. From our own Tata Main Hospital, Jamshedpur, we have Dr. Richa Tiwari, Dr. Sana Afreen, Dr. Bhavya Chaudhary, Dr. Raksha. And from CCL, Gandhinagar Hospital, CCL Ranchi, we have Dr. Lalita Priya, Dr. Firdos Jahan. From Bokaro General Hospital, we have Dr. Nupur Gupta, Dr. Hospital. Yeah, sorry, I just was interrupted in
Your
between.
voice
So,
is
Kashyap Eye
breaking.
Hospital, we have Dr. Neeraj Jha and Dr. Sakshi. So, coming to the outer circle, we have from Rio Rims, Ranchi, Dr. Anamika Chaudhary. From Bhagwan Mahavir Manipal Hospital, Ranchi, we have Dr. Pooja. Dr. Nidhi Sharma is from MGM Jamshedpur. Dr. Anamika Thakur, Bokaro General Hospital. And Dr. Ujjwal is also from Bokaro General Hospital. From Kashyap Memorial Eye Hospital, Ranchi, we have Dr. Gagandeep Singh Gulati, Dr. Shubham Singh, Dr. Ishaq.
Okay. So, madam, you are not audible.
It seems that her connectivity
sorry,
is a
ma'am.
little poor.
Am I audible now?
Yes,
yes. Yeah, better, much better. Yeah.
So I welcome everyone. So to the session, let us start the session, please. Thank you so much.
So before that, I will request everyone to open their window because we have to take the pictures. Please open your window. Premlata, please capture. Please open your window. Because for each session, we have to take pictures.
Dr. Bharti, am I visible?
Yes, yes.
Thank you.
So, Dr. Neha Chaudhary, are you here?
Yes, ma'am. Yes, ma'am. I'm here.
Okay, सब अपना अपना window खोलो. Photo हो गया. So first we will take up the case of Dr. Neha Chaudhary, 5 minutes, and then Dr. Vatsala Kuwar and inner circle, outer circle, whosoever will be the best. We will be giving every session cash prize 1,000 rupees. And Dr. Shweta Walia and all the guest faculties will decide who is the best discussant of the session. So one discussant from this session, chemical injury. We have 2 presenters. Madam Premlata, have you taken the screenshot? Okay, please start.
Yes.
Neha Chaudhary, over to Neha Chaudhary. Carbide gun injury.
Yes.
Please share your screen. Neha, please share your screen. Yes.
Yes, ma'am. Can I start, ma'am?
Yes, yes, fast. 5 minutes.
Good evening, everyone. I am Dr. Neha Chaudhary, from second year PG resident from MGM Medical College. Today, I am going to present my case. A 17-year boy from Jamshedpur came to emergency department of our institute with chief complaint of blurring of vision in left eye for 2 hours and burning sensation in left eye for 2 hours. My patient presented to the emergency department with chief complaint of blurring of vision and burning sensation in left eye following an accidental blast from a calcium carbide toy gun used as a firecracker. There was no history of insect entry. There was no history of installation of eye drop for long term, and there was no history of ocular surgery or contact lens use. In the treatment history, the history of prior ocular irrigation at home with tap water was done, and there was no history of use of any ocular or systemic medication before hospital presentation. In past history, there was no history of chronic illness and no history of autoimmune disease. In family history, there was no significant history. In personal history, my patient was a student. He had a mixed diet and normal appetite, and there was no history of drug allergy and no history of tobacco and alcohol consumption. In general examination, my patient was conscious and well oriented to time, place, and person. His vitals were stable and pill code was normal, and he was afebrile at the time of the presentation. In ocular examination, in general, the head posture was erect and the facial symmetry was symmetrical. In external examination, the visual acuity of the left eye, the uncorrected visual acuity was 6 by 60 and the best corrected visual acuity was 6 by 24. The IOP of the left eye was 14 and the extraocular movement was full and free in all cases. In slit lamp findings in left eye, in eyelid and adnexa, there was a diffuse lid edema and eyelashes burn and first degree burn over periocular skin. In conjunctiva, the subconjunctival hemorrhage was present nasally from 9 o'clock to 11 o'clock, and there was a diffuse conjunctival congestion. In cornea, the central corneal epithelial erosion of 5 into 5 mm diameter was present and corneal haze was present. The fluorescence stain was positive and the limbal ischemia present from 6 o'clock to 8 o'clock, which was less than the 3 o'clock hour involved. In anterior chamber was normal in depth and quiet, and the iris was brown and regular, and pupil was normal in size and reactive to light. These are the images. The first image which shows the central corneal epithelial erosion of 5 into 5 mm diameter, and the fluorescence stain was positive. And in the second image, we can see that there was a diffuse lid edema and eyelash burn and the periocular skin burn. And the third one is the slit lamp cross-sectional image in which we can see the corneal haze. In fundoscopic examination, the right eye and left eye fundus was within the normal limit. In systemic examination, there was no evident findings were present. My differentials were chemical injury, thermal injury, and toxic keratoconjunctivitis. The blood investigations were done. The following investigation were done, and the B scan of the left eye was done, which reveals a clear anechoic vitreous cavity. The retina is attached throughout. There was no vitreous opacity, RD, and choroidal abnormality, and the lens was in the position. Case summary. A 17-year male presented to the emergency department with complaint of blurring of vision and burning sensation in left eye after an accidental blast from calcium carbide gun, and there was no history of ocular surgery, contact lens use, and no history of long-term installation of eye drop use. On examination of left eye, the uncorrected visual acuity was 6 by 60, the best corrected visual acuity was 6 by 18, and there was a diffuse lid edema, eyelash burn, and primary burn over the periocular skin. And there was subconjunctival hemorrhage and diffuse conjunctival congestion. Central corneal epithelial erosion of 5 into 5 mm present. Fluorescence stain was positive. Limbal ischemia was present. And the anterior chamber iris pupil were normal. And the fundus was within the normal limit. My final diagnosis is left eye chemical thermal injury by calcium carbide under modified Roper Hall grade 2 and Duas grade 2. The management in emergency under topical anesthetic ocular irrigation was done with 2 liter normal saline using IV set, and then by double everting and upper eyelid and the lower eyelid, particular materials and debris was removed and trimming of the burned eyelashes were done. The medical management in left eye, eye drop prednisolone acetate 1%, 1 drop 6 times a day given. Eye drop moxifloxacin 0.5%, 1 drop 4 times a day given. Hometropin eye drop 2%, 1 drop 3 times a day given. CMC 1 drop 4 times a day given. And eye ointment azithromycin locally application at night, and eye ointment D panthenol locally applied thrice daily. Tab vitamin C 500 mg, 1 tab twice daily for 10 days, and tab doxycycline 100 mg, 1 tab twice daily for 1 week, and follow up that after 3 days. In first follow-up visit on day 3, in left eye, the uncorrected visual acuity was 6 by 18 and best corrected visual acuity was 6 by 12. IOP was 11 and the extraocular movement full and free in all cases. In eyelid adnexa, eyelash burn and first degree burn over periocular skin present, subconjunctival hemorrhage was present, diffuse mild conjunctival congestion present, corneal opacity 5 into 5 mm. Fluorescence stain was negative, and the limbal ischemia present, AC was quiet and pupil was dilated pharmacologically. In treatment part, the same medication was prescribed, which was prescribed earlier, and follow-up done after the 3 days. In the second follow-up, on day 6, the patient was symptomatically better. In the left eye, the uncorrected visual acuity was 6/9, and the best corrected visual acuity was 6/9. The IOP was 11, and the extraocular movement was full and free in all gazes. In conjunctiva, there was a mild congestion. In cornea, cornea was clear, fluorescence stain negative, and there was no limbal ischemia. AC was quiet, and pupil was dilated pharmacologically. And then in treatment part, the eye drop prednisolone acetate 1%, frequency was tapered, 1 drop 4 times a day. And after that, after 1 week, 1 drop 2 times in a day. And after 1 week, 1 drop 1 time, and then stopped. And other medication were continued for next 1 week. This is the Roper Hall classification that we used while grading. And this is the Jhos classification, which we also use. And in our case, it was Jhos grade 2. And this is the pathogenesis of calcium carbide ocular injury. In pathogenesis part, when calcium carbide comes in contact with the water, it will form acetylene gas and the calcium hydroxide. And as we know, the acetylene gas is a highly inflammable gas, which will cause the thermal injury. And the calcium hydroxide, which is a strong alkali, it will cause saponification of cell membrane. Due to that, the hydroxide ion will enter into the cornea stroma and cause collagen and proteoglycan degradation. And the following cascade will happen, and it will cause a limbal stem cell deficiency, and it can cause corneal melting and persistent epithelial defect. And this is the chronic sequelae that can happen, like corneal opacity, corneal neovascularization, symblepharon, dry eye, secondary glaucoma, cataract, and corneal perforation. So the take-home message, as we know, the calcium carbide gun injuries are complex and highly eventful. They are tripartite injuries, which consist of mechanical, thermal, and alkali injury. So prompt copious irrigation is the most critical vision-saving intervention. And we should always suspect the open globe injury, intraocular foreign bodies, and multiple tissue involvement. And the limbal ischemia and the degree of the ocular surface damage are the key predictors of the long-term visual outcome. And these injuries are severe and yet entirely preventable through the public awareness and safety education is needed. Thank you.
Thank you, Dr. Neha, for wonderful presentation. And you can stop sharing your screen.
So Dr. Varsha, Dr. Shweta Walia are the expert panel for this.
Yeah, please go ahead.
So before we start the discussion, I would request all the inner circle and the outer circle residents to ask questions that are pertinent to the case, not just theory, the clinical relevant questions, because we are having a cash prize for the best discussant. So let's start the discussion. And
after this discussion, we will take the second case, right?
Yes.
Yes.
Okay.
So who is going to put up the first question? Dr. Amar Kumar, Dr. Bhavya?
Yeah, good evening, everyone.
Amar, yes.
So in medical management, as we see that you use corticosteroid eye drop. So if patient has still ongoing ocular surface inflammation, then what we should do? Should we continue the corticosteroid eye drop, or should we stop the corticosteroid?
Actually, we give a corticosteroid to reduce the inflammation. So we will continue the steroids.
So anyone would like to counter the answer of Dr. Neha? Is it correct? Dr. Amar, what do you think? How long the corticosteroids need to be continued and when they should be stopped? Dr. Amar, would you like to highlight?
Yes, ma'am. Yes, ma'am.
Yes, please.
Corticosteroid eye drop should we stop? Then we should add some topical preservative-free lubricants to continue and taper it as the duration increases.
So very correct. We need to stop steroids after 7 to 10 days, irrespective if the inflammation is there, because collagenase activity starts after that, and there can be corneal melting if we continue with the steroids. So, thank you, Dr. Amar. Dr. Bhavya, would you like to ask any questions to Dr. Neha?
Dr. Shweta, if I may interrupt at this point,
So,
or
yes, yes, we can, but actually the experts have to answer after at the end, once the discussion is completed by the residents.
Okay, sure.
First, the inner circle, outer circle, they complete their discussion.
So by that, we come to know what is their take on the knowledge, how well they have taken up the chemical injury part in any case.
Anamika, Vatsala.
Yes, ma'am.
Yes, Dr.
Good
Anamika.
evening, ma'am. Just one thing I want to know, that you mentioned that the best corrected visual acuity was, I guess, 612 or something around. So is it what is the rationale behind taking the BCVA when there's a 5x5 mm epithelial defect? And I think I just wanted to know, because according to the studies, and they say that it is not advisable to take the BCVA just immediately, because the vision deteriorates in the later phases, and also with such epithelial defect, patient will have a associated photophobia, watering, so the refraction is not possible, or it's a bit difficult to do at that stage. So was it the pinhole vision or the actual refractive vision?
It was a pinhole vision.
It was a pinhole vision, not the refractive vision. So you need to mention that it was a pinhole vision. Anyway, very good presentation. Thank you.
Thank you, Dr. Anamika.
And what was the rationale behind using azithromycin ointment or the D-panthenol ointment?
Like azithromycin, like it will help to inhibit the metalloproteinase enzyme, so it will effective in collagen synthesis, as it is a anti-cholangiolytic substance.
Okay, and anti-glaucoma medications were not added?
Were not added because IOP was within the normal limit. That's why it was not added at that time.
Okay. Thank you.
Thank you, Dr. Anamika. Anyone else from inner circle? Dr. Lalita, Dr. Mayank, Dr. Neeraj would like to ask the question? Dr. Firdaus? If there is no one from inner circle, we'll move to the outer circle. Dr. Sakshi, are you there, Dr. Sakshi?
Yes, ma'am.
Yes, please. You want to ask something? You are gone muted again.
No, ma'am.
Okay, so the inner circle has no questions to put to Dr. Neha. Let's move on to the outer circle, who are the second years and the third years. Dr. Anamika Thakur, Dr. Gagandeep, Dr. Shubham, who is going to put the question to Dr. Neha? I think everyone is satisfied with your presentations and there are no questions to you. Anyone?
It was a good presentation with details.
Yes, the details, and she had added the theory part also, and
Yes.
why it's all complete.
So Anamika Chaudhary is from outer circle.
Yes, she was from outer
circle.
circle.
Amar, Anamika, they answered well, participated well. So should we take up the next person?
No. I have a question to ask to Dr. Neha for the knowledge of all the PG students. Everybody is mentioning you irrigate. How do you irrigate, Neha?
So we will use the hypertonic solution, like
No. How do you do? Tell me the procedure. What do you do? You don't put a glass of water and put it on the eyes, of course not. So what do you do that?
Connect the IV set to the to the NS or to the RL bottle, and we will irrigate from medial canthus, from the medial towards the lateral canthus, and also we will double evert the eyelids and also irrigate in that area also. We will also irrigate in fornices, both in upper and lower eyelid, and we will continue it for about 30 to 60 minutes, and approximately according to books, 3 liters fluid should be used, and in every 10 to 15 minutes pH should be checked. But in our center, as we know, the litmus paper was not present in emergency department, so we didn't use that in that time.
Got it, Seema. Tell me one more thing, just one more question. Yes. Do you tell your patients what will happen after the irrigation? No. So there's going to be, a lot of chemosis after you irrigate, with such a lot of irrigations. This is just for your knowledge. You get 100% marks from me. Fantastic.
Thank you,
Madam,
Dr. So can we take the expert comment and then we can move on to the
next
second
speaker?
Yes.
Firdaus, you are asking something, Firdaus?
So, ma'am, about topical steroids, actually, we don't stop them after 7 to 10 days these days, because active ongoing inflammation is actually a cause for non-healing epithelial defects. So we actually continue that. It is true that presence of an epithelial defect will lead to underlying melting of the stroma, but if the inflammation is not taken care of, your defect is actually not going to heal. So we continue the steroids. We don't stop them after 7 days, 14 days, which was like a concept which was previously practiced. But these days we continue the steroids, and depending on the severity of the injury, actually we would start them even 1 hourly for some patients with a grade 6 injury, and then taper them off weekly. You can give oral doxycycline, tetracyclines for the collagenollytic, anticollagenollytic effect. So that is one thing that I wanted to highlight, that steroids are important in the acute phase. And if the effect is not healing, find out the cause why it is not healing. If it's a grade 6 injury, if there is an ischemia, it will not heal. So unless ischemia, your defect is not going to heal. If the pressures are on the higher side, and if you're not adding an AGM, your defect is not going to heal. So there are multiple other factors which also need to be looked at.
Thank you, ma'am.
Thank you. You are an ocular surface person in the ascent, so naturally we are going to listen to you and follow you. So the message is the longer period, especially if the injury is deeper. Okay. So let's move to the next speaker, and Dr. Vatsala.
Good evening, everybody.
Good evening.
So is my slide visible, ma'am?
Yes, yes.
So I'm going to present on chemical injury of the eye, and my guide is Dr. Rahul Prasad, sir. 29-year-old male, driver by occupation, resident of Ranchi, came to the emergency at 9 p.m. after chemical injury in his eyes from his bike's battery splash with the complaint of burning sensation in both the eyes since 12 hours, pain in both the eyes, watering in both the eyes, and redness in both the eyes since 12 hours. History of presenting illness. My patient sustained a history of chemical injury from a fluid that splashed from his bike's battery on his face and eyes 12 hours back. He complained of burning sensation in both the eyes since 12 hours. It was associated with diminution of vision, which was sudden in onset and painful. It was also associated with watering from both the eyes, photophobia, and redness. He washed his face and eyes with tap water and went to a local eye hospital in Ranchi. There he was examined and was diagnosed with both eyes corneal abrasion with limbal damage. He was prescribed some topical and oral medications and was referred to the higher center for further management. For this complaint, he visited our hospital. Past ocular history, no significant ocular past history. Past medical and surgical history, no significant history, and no significant family history as well. The Personal history, patient has normal appetite, normal bowel and bladder habits, no addiction to any known substance. Social history, he belonged to lower middle socioeconomic group. General examination. Patient was alert, conscious, cooperative, and well oriented to time, place, and person. Patient was of average build, fair in nutrition. The vitals, the temperature was, if he was afebrile to touch, the pulse was 66 beats per minute, blood pressure was 110 by 70 millimeters of mercury, and respiratory rate 16 cycles per minute. No sign of pallor, icterus, clubbing, cyanosis, lymphadenopathy, and edema were noted. Systemic examination was within the normal limit as far as the cardiovascular system, respiratory system, central nervous system, and the gastrointestinal system was concerned. Ocular examination. On ocular examination, for the right eye, his uncorrected visual acuity was 624, and for the left eye, it was 618. There was no improvement. Globe position and size were normal. For the eyelid and adnexa, the lid swelling with upper eyelid abrasion was seen in the right as well as the left eye. For the right eye, the conjunctiva had chemosis with diffuse congestion and stain was negative in the conjunctiva. For the left eye, the chemosis was diffuse with congestion. Staining was present in the medial half area. Cornea epithelial defect, which could be seen as 10 into 8 mm. And for the left eye also, the epithelial defect was seen 7 into 7 mm. Limbal staining was absent. The anterior chamber had normal depth. The pupil were normal in shape, reactive to light. The lens were clear, and the IOP measured by NCT at 9:30 p.m. were 14 and 16 millimeters of mercury. This is the picture of the right eye and the left eye, showing corneal staining 10 into 8 and 7 into 7 millimeters. On fundoscopy, the media was hazy. The optic disc had normal shape, normal color, CDR 0.4, margin well defined, and the neuroretinal rim was healthy. Same for the left eye. The blood vessels, normal in caliber, arising from the central disc, dichotomously branching with the AV ratio of 2:3. Macula, the foveal reflex could not be visualized due to hazy media in both the eyes, and the periphery was within the normal limit. So this is the Roper Hall grading, which take into account the limbal ischemia and the corneal involvement, and it has 4 grades, 1, 2, 3, and 4. And the prognosis is good in the first 2, whereas it is guarded in the third and poor in the fourth one. For the corneal involvement, first has epithelial damage, second has haze, but the iris details are visible, and the limbal ischemia is less than 1/3. For the third grade, the corneal involvement is total epithelial loss with haze that obscures the iris details, and the limbal ischemia is 1/3 to half. And the fourth grade, cornea is opaque with iris and pupil obscured, and more than half limbal ischemia. Case summary. A 29-year-old male presented to the emergency with a history of chemical injury in the eyes by bike's battery. He complained of burning sensation in both the eyes since 12 hours, associated with pain, watering, redness in both the eyes. Systemic examination was normal. His best corrected visual acuity was 624 in the right eye, 618 in the left eye on day 1. On anterior segment examination, he had abrasion and swelling of both the eyelids, chemosis with diffuse congestion in both the conjunctiva. Stain was positive on the medial side of conjunctiva in the right eye. Epithelial defect was seen of the cornea, 10 into 8 in right eye and 7 into 7 in the left eye. The IOP was normal in both the eyes. On fundoscopy, the media was hazy. The FR could not be appreciated. Rest was within normal limit. My differential diagnosis is acid chemical injury and the alkali chemical injury. Since he got splashed from his bike's battery, so it is H2SO4. So we take the provisional diagnosis as acid chemical injury. Both eyes grade 1 acute acid chemical injury according to Roper Hall classification. Management and treatment, thorough wash with appropriate 10 liters, there's a misprint, 10 liters of ringal lactate was done in both the eyes of the patient as soon as he came to the emergency, and then his vision was taken and slit lamp examination was done after this, and eye drop prednisolone acetate 1 drop was prescribed in both the eyes, 1 drop 2 hourly for 2 days, followed by tapering dose. Eye drop moxifloxacin 1 drop 4 times daily was advised. Eye drop polyethylene glycol 1 drop 1 hourly. Eye drop homatropin 2% 1 drop 2 times. Eye drop chloramphenicol and polymyxin B were asked to be applied at bedtime. tablet vitamin C 500 milligram 4 times a day for 14 days, and tablet Eslofenac serratiopeptidase paracetamol SOS basis, and tablet pantoprazole empty stomach, so that he can take all these medications. Patient was called for review daily for 6 days and then on the 15th day. So this is the follow-up on the 6th day. As we can see, some SPKs are still, we can see in the right as well as the left eye, and mild lid abrasion was also present in both the eyes. Rest everything was within normal limit, and this was on follow-up 17, and everything came back to normal, and patient is currently under observation and on monthly follow-up. Thank you.
Thank you, Dr. Vatsala, for excellent
So over to the Dr. Shweta Walia, our moderator.
Thank you, Dr. Bharti. So the case is open for
everybody. Please open the window because we have to take picture.
It is also better to interact when the videos are on. So who is going to ask question to Dr. Vatsala? Dr. Amar,
Inner circle.
Dr. Nupur, Dr. Lalita, Dr. Mayank. Who is going to ask?
Inner circle.
Good evening, everyone.
Yes.
So, ma'am, as seen in slide that subconjunctival hemorrhage or subconjunctival chemosis is present. So, how will we differentiate between true limbal ischemia or subconjunctival hemorrhage or chemosis between them, and how our treatment differs when you know is it true limbal ischemia or subconjunctival hemorrhage or chemosis?
Okay, thank you for the question, Dr. Amar. So when it is limbal ischemia, on a slit lamp examination, that the sclera is completely white because the blood vessels are not able to go there. As far as when there is hemorrhage, subconjunctival hemorrhage, redness would be seen beneath the conjunctiva. And for the chemosis, the swelling of the conjunctiva could be seen.
And how treatment differs when we know that it is true limbal ischemia?
Yeah, so once we diagnose it as true limbal ischemia, if the ischemia is in little clock hours, we'll just observe. But if it increases, we can do tenonplasty, as Varsha ma'am already said, so that we can gain back the blood supply.
Yes, thank you.
So wonderful, Dr. Vatsala. Anyone else from Inner Circle who wants to ask question to Dr. Vatsala? I think your presentation was self-sufficient and they don't have any questions. Anyone from Outer Circle? Dr. Firdaus, Dr. Sonia, Srishti,
Dr. Irshad. मतलब सब तुम्हारे सामने फेल हो गए, किसी के पास कोई क्वेश्चन नहीं है,
कोई झगड़ा करना चाहता ही नहीं है.
Yes, Dr. Nidhi, you want to ask something, please?
Yes.
Ma'am, I want to ask why did ma'am didn't use Dua's classification and she just used Roper Hall classification for grading the chemical injury?
No, actually, Dr. Nidhi, I used both the classification. I just showcased the Roper Hall classification. According to both the classification, the injury was grade 1. As far as the Roper Hall classification is concerned, the limbal ischemia and the cornea is judged, whereas for Dua, the conjunctival involvement and the limbal ischemia is judged.
Okay, ma'am. And ma'am, the EPICS classification, which has recently been, it is better than Dua's classification, ma'am, in what respect?
Because it takes into account 4 things. Apart from the epithelium that we already take into account, we take into account the pressure and EP, I, and X. The exposure and the I am unable to recollect. Is it IOP?
Ischemia.
Ischemia.
Yes, ma'am. Ischemia.
Good. Anything else, Dr. Nidhi? Okay. Anyone else?
Yeah, I want to ask a question. Hello.
Yes, Dr. Ajay. Yes.
I want to know if a patient came with the chemical injury. So we see first the nature of injury, how much ischemia is there, and most important is the epithelial defect. The area of epithelial defect, whether it is recovering or not. So frequent follow-up is also important. The most important, what she forget to tell, if a 55-year-old or aged patient come with chemical injury, the most important investigations should we do before starting this treatment. So let me know what important investigation, systemic investigation should we ask. Like we start systemic steroid or topical steroid. So better to investigate blood sugar and systemic parameter, whether all these parameters are okay or not. If we start steroid in a diabetic patient, so the condition may become hell. Number one. Number two, the amniotic graft, we use amniotic graft that depends on the severity of limbal ischemia. So it should be ideally placed within 7 days, within 7 to 10 days of injury. So this is also very important.
Thank you, Dr. Ajay, for your inputs. Anyone from inner or outer who would like to ask? So let's move on to the expert comments. Dr. Varsha, please give your experts comments for the presentation and the questions.
Very nice presentation, Dr. Vatsala. The one important point that you highlighted was that the vision and the slit lamp examination is done after irrigation. So that is actually practically very true. When a patient comes to your emergency room with the complaint and when you suspect that it's a chemical injury, you do not, you actually go and irrigate, remove off any inciting agent and then actually examine the patient. Another important point, when you are irrigating, it's a very painful procedure. So always anesthetic, topical anesthetic solution is applied and
फिर खत्म हो गया.
It's a very painful procedure. So 5 to 10 times probably putting topical, even while you are irrigating topical anesthetic solution, it actually helps the patient. I would have liked it if you would have given a DUA's classification and more if you would have given an EPICS classification, because in practical practice as of today, we do not follow Roper Hall as such. It's more of a theory basis that if you want to put a grade, Roper Hall grade 3, but it actually we do not follow DUAs, and more recently some centers follow EPICS. I would like to know this, the question is open to everybody, to all the PJs. What are the when there was a classification which is a Roper Hall and from there we shifted to DUAs and now recently to EPICS, why is it so? What are the cons of these classification that are taken care of by the subsequent classification? Like why you follow DUAs and not Roper Halls? If anybody can tell.
Ma'am, because it takes into account the IOP and the ischemia.
No, that is the EPICS classification. I'm speaking about DUAs. So what is it that DUAs has an advantage over the Roper Halls?
Ma'am, more superior because of predicting the surgical outcome. Because it involves it to give information about the conjunctival involvement.
Yeah, true. But the two cases that Dr. Vatsala and Dr. Neha presented, both of them were grade 1 Roper Hall, grade 1 DUAs and grade 2 Roper Hall and DUAs. So the grading in that 1 and 2 was the same. So the prognosis is also almost the same. So then how DUAs is better than...
Actually, for the 4th classification of Roper Hall, the DUA take into account as 5th and 6th. So that makes the difference.
Exactly. So what was seen was that grade 4 of Roper Hall, all the cases that fall into grade 4 of Roper Hall actually do not have same prognostication. It actually depends on many other factors. And that's why DUA classified them into 4, 5, and 6. So 1, 2, 3 remains the same mostly. It's the 4 that has been subclassified into 4, 5, and 6. And what does DUAs take into account? Limbal ischemia?
Limbal involvement and conjunctival involvement.
Roper Hall takes into account limbal ischemia
and cornea.
limbal defect. while Jhos takes into account a limbal defect also. Even if there is no limbal ischemia, it is graded as limbal involvement, which is more prognostically predictive of the futuristic limbal stem cell damage. What EPICS, obviously, I think I would have highlighted, so you would be able to answer, is that EPICS takes into account more than the conjunctival involvement and the defect. It's only
18 millimeter of mercury. So what are corneal dystrophies? These are heterogeneous group of inherited disorder. They are typically bilateral, hereditary. They are non-inflammatory, slowly progressive disorder. Usually they are not related to any environmental or systemic factor, mainly dominant, and they are common in first and second decades. So these are certain classification of IC3D classification is there, which is based on the gene mapping and the specific mutations are there. And then further there is a classification based on the locations of it, that is the epithelial, subepithelial variety, the epithelial, stromal, TGF beta 1 varieties, the stromal varieties and endothelial varieties are there. They are further classified baselinely. So my case was a macular corneal dystrophy, which is an autosomal recessive associated with the CHST6 gene mutation. There is an inborn error of keratin sulfate, so the unsulfated keratin get deposit. They have a clear cornea at birth and they begins by 3 to 9 or present with decreased vision by 10 to 30. White opacities with indistinct edges are there with diffuse stromal haze. Glycosamine glycan get deposit. So histopathologically, they will stain with the Alcian blue and the colloidal iron. Treatment is the banded contact line. Initial stage can be given. Definitive treatment are the keratoplasties. Thank you.
Thank you, Dr. Sonia, for wonderful presentation. And let's start the discussion. The experts for this session are Dr. Nivedita and Dr. Charuta Puranik. And who from the inner circle going to start the discussion? No one is going to take the lead?
Hello, good evening, everyone.
Yes, please.
Hello. Can you please tell me which kind of keratoplasty you have done? Like you have done full thickness pen optical keratoplasty or deep anterior laminar keratoplasty?
Yeah, it depends based on the opacity depth. If it is not involving deeper stroma of the endothelium anyway, by ASOCT we can see, or by slit lamp evaluation, we can go for deep anterior lamellar keratoplasty. But if there is any suspicion of endothelial involvement or deeper stromal involvement, as macular do have more deeper involvement, so we can go for penetrating keratoplasty in those cases.
So in your case, more deeper tissue was involved.
Deeper involvement was there. In periphery part, there was more deeper involvement of dystrophies.
That is, you went for optical keratoplasty.
Optical penetrating keratoplasty.
Oh.
Thank you, Dr. Irshad. Anyone from inner circle? Dr. Bhavya, Dr. Nupu, Dr. Lalita, Dr. Mayank, Dr. Vikas. Last time you all were very active. This time, I don't know why you're not asking questions. Either the presentations are too good that nothing is left to
most
ask.
of them in my hospital, they are having exam.
Right. Maximum participation was from Kashyap Memorial last time. Gagandeep was very active last time.
Yeah, Gagandeep has disappeared because of exam. I coaxed Irshad. Then he was doing emergency duty. He came.
So who is going to ask? Dr. Neeraj, Adarsh, Dr. Pooja, Dr. Rahul, anyone?
Good evening, everyone.
Yes, good evening, Srishti, please.
Nice presentation, Dr. Sonia. My only question is, what are the important parameters that you'll check and are important in the post-op period?
Yeah, so first we will check, obviously we'll check the visual acuity for which we are doing. We will check the graft clarity, any sign of any rejection or failure or any infiltrate infection we will check. We will surely check the intraocular pressure. There is a high risk of glaucoma post-penetrating keratoplasty, so we will check these parameters.
Thank you, Dr. Srishti. Sakshi, you want to ask something?
Sakshi, you are working with Dr. Nidhi. You are in Cornea. Irshad is also working with Nidhi.
Yeah, I want to ask one more question. If
Yes,
hello,
yes. Yes,
if
please.
only superficial layers of cornea are involved, so what is better to do? Like, can we do phototherapeutic keratectomy or we can go for dark? Which one is better?
Phototherapeutic keratectomy should be done only in very superficial where there is patient symptomatic with recurrent erosions, multiple erosion not involving the visual axis. Otherwise, we will go for deep anterior lamellar keratoplasty because macular dystrophy do have recurrence and they generally have deeper involvement. So multiple opacities will still be present. So visually
So,
not significant.
so dark is better.
Thank you, Dr. Sonia. Anyone else who would like to ask question?
Yes, ma'am.
Yes.
Sonia, very nicely presented, first of all. Congratulations for that. And how do you differentiate macular from granular corneal dystrophy? And what is the role of ASOCT in determining your plan of management in such cases?
Yeah, macular and granular both have a different inheritance as well. And by clinically, we will see the intervening stroma in granular will be clear. There are breadcrumbs like appearance. The intervening stroma won't be hazy in them, whereas macular will have a stroma, intervening stroma would be involved. And ASOCT will have a role like to determine we will go for DALC or PKP. As macular, the periphery will have a deeper involvement which won't be visible under slit lamp. So by ASOCT, we can see the corneal thickness and the deeper involvement of the opacities which are present on the peripheral cornea.
Yeah, thank you so much, Sonia. And if endothelium is involved, definitely we'll go for PKP. We can go for DALC if the superficial layers are involved, and DALC has a better acceptance rate, and the rejection rate is more in PKP because in DALC the endothelium is not
Still
intact, so the
intact.
rejection rates are very nicely
Yes.
presented. Thank you.
Thank you, Dr. Anamika and Dr. Sonia. Anyone else who would like to question Dr. Sonia? So let's move to the experts and take what they have to say. Dr. Nivedita, your inputs, please, for the case.
Yeah, very nice presentation. Congratulations to the presenter. She has highlighted a very important aspect of corneal dystrophy, the toughest one probably. I just want to ask her, when will you plan for suture removal? One. And what will you look for recurrences? Is it possible for a recurrence in macular dystrophy?
Yeah, macular do have a recurrence rate is there. And after 1 month post surgery, we can go for suture removals, checking the uh, tightening or loosening, flattening of the cornea or steepening of the cornea.
In a penetrating keratoplasty, 1 month is too less now. So 1 year is what is the guideline, like any keratoplasty. So loose sutures can be removed early.
Loose suture, okay.
So recurrences are very common.
Recurrences are common.
Very common.
Very
So
common.
you need to be very careful about it. When will you plan for the other eye? Because you said your patient is having a bilateral condition.
Bilateral keratoplasties,
So
yes.
when is it better to plan for the other eye? How early?
Not much sure, ma'am, about it.
Okay, that's a very valid question because the patient will ask you. If you do a successful penetrating keratoplasty, the patient will ask you. As you told, many complications possible, pressure spike, all of those things have to be settled. You have to wait for at least 6 months.
6 months.
Standard. Very nice. Nice presentation. Congratulations.
Thank you.
Thank you, Dr. Nivedita. Dr. Charuta, your comments, please.
Am I visible?
Your voice is too low. If you can speak loudly.
Excellent presentation, Dr. Sonia.
Thank you.
So you mentioned in the passing about keratin sulfate staining. I'm wondering whether do you understand you classify based on keratin sulfate staining?
It is
Keratin sulfate staining. Yes.
stains with Alcian blue. It stains with colloidal iron also. It is the glycosamine glycans which get deposits.
So
Unsulfated keratin.
based on the keratin sulfate staining, there is a classification. Class 1, Class 1A and Class 2. So that is of slight importance because class 2 is having normal keratin
Levels. Yeah, ma'am. Based on the serum deposits and the corneal deposits.
correct.
Yeah.
Also recurrence rate, like what has been mentioned before, slightly higher in group 2.
Group
But
2.
while
Yeah.
counseling, you can say that it would take many years or decades also, but there is a possibility.
Yeah, and type 2, they will have the keratin sulfate in serum as well as in the corneal deposits.
So another thing is regarding the description of the graft. We need to understand that when you mention the graft host junction, you have to notice several points. So whether the sutures are adequately tight or loose, whether there is any override or underride or not. So I think the mention was very brief and not very adequate for the
Okay.
exam point of view. But overall, good, very well managed, very well presented case of macular dystrophy, and also good questions from the postgraduates.
So
So
who will you say asked the best question? Dr. Irshad asked on whether to go for DALK and when to go for PK. And Srishti asked upon parameters to check in post-operative phase. And Amika asked how to differentiate macular and granular dystrophy and the role of ASOCT. So, Dr. Charuta, the best question.
of course, all three questions are very pertinent. You have to know how to monitor a patient post keratoplasty and the distinction between DALK and PTK, whether that is actually an option in these cases. It was well answered by Dr. Sonia. And Dr. Anamika's question was also very pertinent because we see a lot of blanket investigations being advised by youngsters. So knowing when to advise which investigation is, according to me, one of the most important judgment questions. So my vote would go to Anamika.
So thank you, Dr. Charuta.
Thank you,
And
ma'am. Thank you
the
so
winner
much.
for this session is Dr. Anamika.
Thank
Congratulations,
you, ma'am.
Dr. Anamika.
Thank you, ma'am.
And over to Dr. Bharti to take over and move on to next session.
So over to Dr. Bharti Sharma for the vote of thanks. Are you here, madam?
Yes, ma'am. Yes.
So,
So
madam,
thank you, everyone. Yeah. So, ma'am, I really need not to say anything. It was a very exciting session, and I have also attended this for the first time. I encourage all the PGs to please actively participate, as it is a very beautiful session, and it is the more you ask, the more you learn. And thank you so much for the faculty for making it so interesting and encouraging, Dr. Charuta and Dr. Nivedita from SN. I know her from long time. And thank you all the seniors for being there to be giving their expert comments, and all the PGs for their active participation. Hoping to see you more participation, more aggressive fighting, participation from all of you. Thank you so much. Thank you, everyone.
Thank you, Dr. Bharti, for your enthusiasm and energy, and very nicely conducted, and so much planning. Wonderful, good,
thank you,
good
thank you. So
energy
you
from
are there
everyone.
tomorrow also. You are there tomorrow also in leadership session.
Thank you,
So
ma'am.
thank you all. So now we are starting. We are getting delayed. Because we have kept 4 sessions. So we are now heading to the third session, the retina session. And I invite Dr. Rahul Prasad. He is the associate professor, Retina Department, Rio RIMS, Ranchi, to introduce none other than Dr. Padma Malini Mahendra Das. She is heading UVA and in Retinal Infection Department of Narayana Nitrale. Over to Dr. Rahul Prasad.
Thank you, ma'am. Very good evening. And can I have the introductory slides, please?
Premlata ji? Premlata?
So far, the discussion on chemical injury and cornea was excellent, ma'am. I was there in the sessions. So yes,
Okay, she is doing.
yes, ma'am. Thank you. Thank you, ma'am. And I welcome Dr. Padmanani Mahendra Das from Narayana Netralaya, Bangalore. She is the head of the uveitis and the ocular immunology services. She is a member of International Uveitis Study Group and an International Ocular Inflammation Society. She is the president of Uveitis Society of India and vice president of Society of Inflammation and Research. To her, she has 218 indexed publications, 45 non-indexed publications, 42 book chapters, and 23 awards to her credit. Welcome, ma'am, and a very good evening to you.
So please introduce one-line introduction of the presenter and the inner circle and the outer circle.
So the presenter for today would be Dr. Neeraj Jha. He is from Kashyap Memorial Eye Hospital. And then the postgraduates who will be joining us in the inner circles are Dr. Amar Kumar from MGM, Dr. Mayank Sharan from MGM, Dr. Vikas Thakur from MGM, and Dr. Neha Chaudhary from MGM. Then we have got Dr. Bhavya Chaudhary from TMH, Dr. Raksha Kumari from TMH, and Dr. Richa Kumari and Dr. Sana Afrin also from TMH. Then from Gandhinagar Hospital, we have Dr. Lalita Priya and Dr. Firdoz Jahan. From Bokaro General Hospital, we have got Dr. Nupur and Dr. Tushar joining us. Then we have got Dr. Anchit Parikh from Kashyap Eye Memorial, Dr. Sakshi from Kashyap Eye Memorial, and of course, Dr. Manju Kumari from RIO RIMS. From the outer circle, we have Dr. Anamika Chaudhary, she is from RIO RIMS, Dr. Vatsala, again from RIO, Dr. Nidhi Sharma from MGM Jamshedpur, Dr. Pooja Tanwar from Bhagwan Mahavir Manipal Hospital, Ranchi, Dr. Anamika Thakur from Bokaro General Hospital, and Dr. Ujjwal also from Bokaro General Hospital. From Kashyap Eye Hospital, we have got Dr. Gagandev and Dr. Shubham, Dr. Irshad, and Dr. Pragya joining us in the inner hospital. So
no, these are outer circle. These are outer circle.
Yes, sir, both inner circle and outer circle done, ma'am.
Okay. So over to Dr. Neeraj Jha. Neeraj, are you there? Neeraj?
Yes, ma'am. Yes, ma'am.
Please share your screen. Dr. Neeraj Jha is the first year DNB student in Kashyap Memorial Eye Hospital. Okay. Yes.
My screen is my screen visible, ma'am?
Yes, it's visible.
Yes.
Good evening, everyone. Myself, Dr. Neeraj, DNB resident, Kashyap Memorial Eye Hospital. I am presenting a case, and my guide for this case is Dr. Vibhuti Kashyap sir and Dr. Pallavi ma'am. A 40-year-old female presented with bilateral progressive diminution of vision since 1 month to our OPD. The patient was apparently all right 1 month back when she developed gradual progressive painless diminution of vision in both eyes. The diminution of vision was insidious in onset, progressive, bilateral, painless. There is no history of ocular pain, redness, watering, trauma, photophobia, flashes, and flutters. There was a past history of fever 2 months back with generalized weakness. There is no history suggestive of diabetes mellitus, hypertension, tuberculosis, HIV, or any autoimmune disease. On examination, patient was alert, conscious, and cooperative. Facial symmetry was normal. Pallor, icterus, cyanosis, clubbing, and edema were absent. Lymphadenopathy was also absent. The pulse rate of patient was 84 beats per minute and blood pressure was 110 by 80 mm of Hg. The patient was afebrile. On visual acuity, both uncorrected visual acuity and best corrected visual acuity was CFC in both eyes. On ocular examination, the color vision could not be accessed in both eyes. Ocular movement was full, free, and painless in all direction of gaze in both eyes. Eye wall position and size was normal in both eyes. On slit length examination, lid was normal in both eyes. Conjunctiva normal in both eye. Cornea transparent. Anterior chamber has normal depth and content in both eye. Pupillary reaction, direct and consensual, both are sluggish in both eye. RAPD were not possible and lens clear in both eye. On posterior segment evaluation, media haze because of vitritis, disc blurred margin, hyperemic disc in both eyes, posterior pole, yellow-white necrotizing retinitis involving the posterior pole in both eye, macula involved by active retinitis and retinal edema in both eye, retinal hemorrhage. There are multiple intraretinal hemorrhage associated with retinitis in both eye. Peripheral retina were attached, no retinal detachment or breaks were found. On investigations, we did ocular investigation, OCT, central retina, and ultra wide field fundus photography. Lab investigations, we go with CBC with ESR, LFT, RFT, serum age, HbA1c, HIB, HbSAg, HCV, VDRL, quantiferon TB gold, and torch profile. When the findings were come, CMB IgM were positive. There was elevated CMB IgG titer, HSB IgG elevated, rubella IgG elevated, and ESR were raised. This is the ultra wide field photography. There we can see multiple white, yellow-white active chorioretinitis lesions and retinal vasculitis. In OCT, we see that there is macular edema, loss of foveal contour, and retinal thickening. From there, we came to the differential diagnosis of CMB retinitis or acute retinal necrosis, progressive outer retinal necrosis, toxoplasma retinochoroiditis, and tubercular posterior uveitis. Provisional diagnosis we made was bilateral CMB retinitis because the points in support of this is bilateral necrotizing retinitis, positive CMB serology, and clinical retinal findings. Treatment plan, we give intravitreal ganciclovir 2.5 mg per 0.1 ml twice weekly for 3 weeks in both the eyes, followed by oral van-ganciclovir. Induction therapy, we give 900 mg twice daily for 14 days and maintenance therapy 900 mg once daily for 90 days. Every 3 weeks, we monitor complete blood count, liver profile test, and RFT. The clinical recovery, patients show significant anatomical recovery, resolution of retinal lesions, and marked visual improvement from CFC to 6/18 in both eye. Visual outcomes from subsequent follow-up. On first visit, patient was CFC in both eyes. On first follow-up, after first week, when we give intravitreal ganciclovir, visual acuity improved in right eye 460 and in left eye 660. On second follow-up, after 2 weeks, right eye visual acuity was 660 and left eye was 560. On third follow-up, it was 624 and left eye also 624. On fourth follow-up, after fifth week, visual acuity in both eye became 618. Posterior segment evaluation post-treatment, media was clear, no significant vitritis in both the eyes. Optic disc, normal color and margin in both the eyes. Posterior pole, healed chorioretinal scar with pigmentary changes in both eyes. Macula, retinal edema resolved, residual foveal structure. And retinal hemorrhage also resolved, retinal vessels reduced and resolved with retinitis in both eyes, peripheral retina attached, no retinal detachment or break in both eyes. This is the ultra wide field photography after the completion of the treatment, and we can say that there is now not yellow whitish chororetinitis, they are resolved. Retinal vasculitis, seeding, they are also resolved. There is no evidence of active retinitis here. This is the OCT after the treatment, and here we can see the restore of foveal contour, and the intraretinal fluid also resolved, and there is organized retinal layers. Summary: a 40-year-old immunocompetent female presented with bilateral progressive painless diminution of vision was diagnosed with CMV retinitis based on clinical finding, retinal imaging, and serological evaluation. The patient responded well with intravitreal ganciclovir and oral vancomycin with significant anatomical and visual improvement. Thank you.
Thank you, Dr. Neeraj, for excellent presentation and an excellent case with very good outcome. So the expert for this session is Dr. Padma Malini. Would like to have inputs from you, madam, after the inner circle and outer circle complete their question and answer. So who from inner circle is going to ask the first question?
Amar Kumar, Mayank Saran, Vikas Thakur, Neha Chaudhary, Bhavya, Raksha, Richa, Sana, Lalita, Firdaus, Nupur, Tushar, Anchit, Pratik, Sakshi, Manju, they are all inner circle.
So we want someone else other than Amar to ask question. The first question from someone else. Dr. Manju, would you like to ask?
Vatsala, any PG from Dr. Rahul department?
Yes, ma'am, I would like to ask some questions.
Yes, Dr.
First of
Vatsala.
all, it was a very nice presentation. I had just 2-3 doubts. So did you get the CD T cell count initially for the patient? And if you got that, till when did you continue your medication? I mean, till what CD count did you continue the medication, and after that you stopped the medication? Firstly, secondly, the patient did not had AIDS. Neither the patient was on immunosuppression, systemic steroid, immunosuppressive chemotherapy. So how is the CMV retinitis came at the first place? I mean, how did the patient develop CMV retinitis?
Ma'am, as we see patient clinically, we evaluated the patient, and because there was a past history of fever with malaise, which saw a little bit of mononucleosis like features. That's why we went through these investigations of torch profile and quantiferon TB also, just to make the differentiation. And there was no history of immunocompromise in the patient, so we did not take the CD4 count initially.
Thank you. I would just like to add that if you would take the CD count, for example, it is 50 initially.
Yes,
so you treat till the T cell count reach 200.
Okay.
Thank you.
Thank you, Dr. Vatsala. Anyone else who would like to ask question? Dr. Pragya, Dr. Nidhi, Pooja, Dr. Shubham. Anyone? So since no one is ready to ask question,
Where
let's
are
take...
you, Dr. Pragya? You have spent so much of time in retina department.
Ma'am, I want to ask a question.
Yes, please. Yes, Neha.
Ma'am, I want to ask if in a patient with severely immunocompromised, how do you manage a case where the clinical appearance is classic for CMV, but the diagnostic PCR is negative? So in that case, what we have to do?
Sorry, ma'am, again, please.
Like in a patient with a severe immunocompromise, how do you like manage a case where you see the clinical appearance is classic for CMV, but the diagnostic PCR for CMV DNA is negative?
Can I take up this question? CMV retinitis, we make the diagnosis based on the clinical appearance. Lab investigations, either the serology or the molecular diagnostics, help us to confirm. If your PCR negative for CMV, we also have to look for other causes of necrotizing retinitis like herpes, Epstein-Barr virus, or varicella zoster virus. You look for other viruses. If that is also negative, then you treat the patient empirically and see the response. Coming to the PCR, we have nested type and also we have a quantitative PCR. The quantitative PCR is more accurate. It calculates the number of genomes present in that. Especially if the patient has compromised renal status where you can't put them on antiviral for a longer time, the quantification helps us not only for the diagnosis but to titrate the treatment.
Thank you.
Thank you so much, madam, for your inputs. And may I take the opportunity to ask who, according to you, asked the best question, either Dr. Vatsala or Dr. Neha? Dr. Padma, madam. Yes, madam. Yes, please.
Coming to Dr. Vatsala's question, it's valid for immunocompromised ones, where we make the CD4 count, we titrate based on the CD4 count and also the clinical picture. Whereas immunocompetent individuals also can develop CMV retinitis like what as Dr. Neeraj has presented. In that situation, these patients will have history of fever or they can have systemic involvement. They can land up with CMV retinitis. In this condition, you put the induction therapy and the maintenance phase depending upon the clinical presentation and the response to treatment. We titrate than going by the CD4 count, like what they did. Coming to the, I vote for the second person.
Dr. Neha. Dr. Neha. Thank you. Thank you. So the
That's
winner.
a practical question. If it comes
Yes.
negative, what do we do? Both are nice questions, but I have to pick up one. So I pick up the Dr. Neha's.
Dr. Neha
Thank you,
is from Rio Rims?
No, ma'am, MGM.
MGM.
Jamshedpur.
Okay. MGM. Okay.
Thank you. Thank you, Dr. Padmalini, ma'am. Over to Dr. Bharti for taking the session further.
Okay. So now we are taking the master class on retinal infection by Madam Dr. Padma Malini Mahendra Das. She is an international faculty and she has already been introduced very respectfully by Dr. Ram Prasad. So over to Dr. Rahul Prasad for one-line introduction of the chairpersons of this session, and then we will go to Madam for the presentation.
Thank you, ma'am. Thank you, ma'am. Thank you once again. So it's my privilege to invite our chairpersons for this particular session. To begin with, Dr. B.P. Kashyap sir is a very well-known figure in our part of the world. He is the organizing chairman of the forthcoming AIS midterm conference in Ranchi. He is also the past president of Jhos and an ex-MC member of AIOS. Then we have got Dr. Vibhuti Bhushan with us. Myself, of course, I'm there. Dr. Soumya Kumari, who is an RPC AIMS trained VR surgeon working at Kashyap Memorial Eye Hospital. We have got Dr. Abhishek Patnaik. He is the VR consultant at TMH Jamshedpur. Then we have got Dr. Divya Prabha. She is our senior resident at RIU RIMS Ranchi. We have got Dr. Manju Shri. She too is the senior resident at RIU RIMS Ranchi. We have Dr. Harish Kumar with us, who is the medical retina consultant in Railway Hospital, Dhanbad. And of course, it feels great to have Dr. Abhishek Sinha and Dr. Komal Soni, who are both senior resident from Dhanbad Medical College and who used to be my students also. Excellent, ma'am. Thank you, ma'am.
So over to you, madam. Please share your screen.
Very good evening to all of you. At the outset, I would like to thank Dr. Bharti Kashyap and Jharkhand Ophthalmological Society for inviting me here today to speak on infective retinitis. Thank you, Dr. Ram Prasad sir, for the kind introduction. So whenever I exceed the time, please tell me, ma'am. I will stop at that point.
So, okay, madam.
Yeah.
It's our privilege. It's our privilege, madam, that you are teaching everyone.
Thank you, ma'am. Retinitis is an infective condition. It's a type of a posterior uveitis. So when we come across retinitis, it's important to differentiate infectious from non-infectious. The non-infectious, commonly what we see is a Behçet's disease. Coming to infectious, it could be due to bacterial, viral, fungal or parasitic. Among the bacterial, we have syphilis, typhoid and rickettsial type of retinitis. Viral, herpetic is the commonest. It could be due to herpes simplex, varicella zoster or CMV retinitis or any other RNA viruses. Fungal, we have Candida and Aspergillus. Parasitic toxoplasmosis is the commonest cause of infectious posterior uveitis across the world. We'll see one by one. First, syphilitic retinitis. Syphilitic is a sexually transmitted disease caused by the spirochete Treponema pallidum. After the emergence of antibiotics, there was decreasing the incidence. Now, along with HIV, we are seeing more number of syphilis cases in our practice. Syphilitic uveitis is a great masquerade. Coming to syphilitic retinitis, they can be distributed in the form of focal, multifocal, or diffuse retinitis. Coming to the pattern, we can have peripheral necrotizing retinitis, neuroretinitis, or retinochoroiditis. Coming to the classical form are punctate inner retinitis, triangular patch of retinitis, or placoid chorioretinitis. Here you could see the autofluorescence images have a placoid chorioretinitis. Whenever we see a triangular patch of retinitis, we need to suspect syphilis or punctate inner retinitis as seen in this FFA picture. How do we diagnose? We have to order both one treponemal, one non-treponemal test. So in non-treponemal, we order RPR or BDRL. It's useful to track the active disease. Once we treat the disease, these tests will become negative. Whereas when we do a treponemal test, they are FTABS or TPHA. They remain positive throughout the life. Coming to the diagnosis, we also have recently the PCR is available. It can be used from the ocular fluids. Syphilis comes under neurosyphilis. So the infectious disease specialists, they may do a CSF analysis and do the VDRL from the CSF fluid. Or whenever we see a patient with syphilis, we also have to screen them for HIV co-infection. Coming to the management, as per the CDC guidelines, we treat syphilis and neurosyphilis. We have different regimens. IV penicillin G, 24 million units, usually for 10 to 14 days course, or IM procaine penicillin, 2.4 million units, can be combined with probenecid, 2 grams. They are equally effective. If the patient is allergic to penicillin, we give IV ceftriaxone treatment. More importantly, not only the patient, but also you have to do the contact tracing and treat the partner as well. Otherwise, they may present with reinfection at a later date. Now, we'll move on to viral retinitis. Whenever we see a patient with viral retinitis, we ask them for a history, fever, skin rash, joint pain, or systemic symptoms. We have to rule out hypertensive retinopathy, SLE, HIV, syphilis, and toxoplasma, other causes of retinitis. After ruled out, then you come to the viral. It could be sporadic in a case of ARN, POR, and CMV, where we do the molecular diagnostics and treat the patient with specific antiviral therapy. Epidemic of force fever retinitis is caused by dengue, chikungunya, West Nile, or rickettsial, where serology or RT-PCR help us to diagnose this condition, treat them with doxycycline plus or minus oral steroids. Many RNA viruses, we don't have specific antiviral therapy, we treat them symptomatically. Novel, we have Zika, Ebola, H1N1, and COVID, SARS-CoV-2 viruses. Coming to the viral retinitis, it's a pattern recognition. When you look at this, it's a medical emergency, like how we have endophthalmitis and viral necrotizing retinitis. It's important. We have to make the clinical diagnosis, start the patient empirical treatment without waiting for all investigations because the virus is eating away the retina. CMV retinitis, you have tomato ketchup or pizza pie appearance, progressive outer retinal necrosis or a PAN as a cracked mud appearance, ARN, acute retinal necrosis as Swiss cheese pattern. Dengue causes hemorrhagic retinitis with retinal hemorrhages. Chikungunya, we have retinitis with retinal hemorrhage. Here is a classical CMV retinitis where we have full thickness retinitis with retinal hemorrhages, disc edema, frosted branch angiitis. It's a fulminant form or hemorrhagic form of CMV retinitis. The other one is a granular form where we could see the granularity there and the hemorrhages are less in this form. Coming to the management, clinical PCR from the ocular fluids useful to diagnose. Ancillary serum antibodies also can be used. Start them with antiviral, systemic, topical, intravitreal. If the patient is HIV positive, after 2 weeks of antiviral therapy, we start them with art therapy. Sometimes they can have retinal break with retinal detachment where we have to take them for surgical management. Role of prophylactic laser is controversial. If they have any retinal break, we do treat them with laser treatment. Drugs used in the treatment of CMV retinitis, ganciclovir, oral valganciclovir is effective as to intravenous ganciclovir. We have a foscarnet, cidofovir. Cidofovir causes severe uveitis following intraocular injections and hypertonic can occur. Or cytomegalovirus immunoglobulins. These are the various drugs we use in treating CMV retinitis. This is a busy slide showing the dose, the route of administration and the side effects. Induction dose is 5 to 10 mg per kg body weight for ganciclovir. It causes neutropenia and thrombocytopenia. When we combined with other myelotoxic drugs, we have to be careful. We have to monitor the counts. Cidofovir causes uveitis following the injection. What are the complications? So, development of retinal detachment can happen during the active retinitis or in the healed atrophic retina can give way and develop retinal detachment. CD4 count is important, especially if it's associated with HIV infection. It helps us to initiation of the heart therapy. Following treatment, patients can develop vitritis and macular edema is in the form of immune recovery uveitis, where we add additional steroid therapy in addition to antimicrobial or antiviral therapy. Next, we'll move on to acute retinal necrosis. Acute retinal necrosis most often is unilateral, rarely it can be bilateral. Immunocompetent individuals, significant vitritis associated with retinal vasculitis and peripheral retinal necrosis. So here we diagnose, if we don't do a dilated fundus examination, we end up missing the peripheral retinal opacification. It's important we need to dilate and evaluate all uveitic patients. Otherwise, we may miss out peripheral retinal changes in a case of early ARN. We treat them with oral valaciclovir or intravenous aciclovir. Oral valaciclovir is 1 gram 3 times a day is equivalent to intravenous route. Or if the patient is not responding, famciclovir and other drugs can be used. We start systemic steroids after 24 to 48 hours of initiation of antiviral therapy. If the patient has ischemic optic neuropathic changes, the aspirin and other drugs can be given. Surgical management we do if there is associated retinal break and retinal detachment. PORN is a nightmare for a treating ophthalmologist. You make the diagnosis, you start the patient on antiviral. Within a couple of days, you can see the extensive progression. They will have a relentless course in spite of putting them on antiviral therapy. Usually they are associated with low CD4 count with HIV infected individuals. The management is similar to ARN where you treat them with antiviral therapy, both intravenous as well as systemic antiviral therapy. The prognosis is poor despite early intervention and appropriate management. Next, we'll move on to toxoplasmosis. Here, we make the diagnosis based on the clinical presentation. Here is a classical case of congenital toxoplasmic scar. Here is a case of acquired retinitis secondary to toxoplasmosis. Here you can see the reactivation of toxoplasmic scar. These are the common patterns we see. We also have punctate inner retinal toxoplasmosis, punctate outer retinal toxoplasmosis, chiral are all atypical form of toxoplasmosis. Headlight and the fog appearance is seen classically. Investigations, we do toxoplasma IgG, IgM or PCR for the toxoplasma. For B1 gene can be done from the ocular fluids. Start the antitoxo treatment followed by systemic steroids. If immunocompromised, we don't treat them with steroids, we treat them only with antitoxo treatment. Diagnosis, ELISA for IgM and IgG antibody. There is something called Goldman-Whitmer coefficient where you comparing the levels of the antibodies from the serum to the aqueous humor. If it is more than 4, it is diagnostic. Other antibodies, IgG ability immunoblotting is useful to find out the chronicity of the infection. So prenatal also we can do PCR testing or amniosynthesis or toxoplasmic antibodies. So it will help us to plan. If the baby is not infected, the spiramycin alone will do. If the baby is infected, then we do antitoxo treatment. And sulfa drug has to be avoided in the third trimester of pregnancy. So you give them combination of pyrimethamine, sulfadiazine and folinic acid. Commonly what we use is trimethoprim with sulfamethoxazole. If the patient is allergic to sulfa, we use clindamycin or pyrimethamine azithromycin combination also can be given. This is a constitution of the intravitreal drug. If the patient has vision threatening lesion is situated in the optic disc and the macula, we do treat them with intravitreal clindamycin with plus or minus dexamethasone. Next, we'll move on to post-fever retinitis. Here, the patients will give history of fever 48 weeks prior to the presentation. Then they will have decreased vision. Many times they may not even correlate. We have to prove them with history. It could be due to typhoid, rickettsial, West Nile, dengue, chikungunya, Ebola, Zika or SARS-2. All this comes under post-fever retinitis category. All of them, they have cotton wool spots like retinitis with retinal vasculitis, hemorrhages in the posterior pole. Serological or molecular diagnostics help us to confirm. Here is a patient who has bilateral. Here you can see the retinitis with retinal hemorrhages, yellowish spots along the vessels. Turned out to be a case of rickettsial infections. Philiphelix was positive. This is a classical OCT where you have hyperreflectivity with aftershadowing with SRF and focal areas of hyperreflectivity corresponding to the areas of cotton wool like spots. This is an FFA, shows hypo surrounded by a rim of hyperfluorescence, and following treatment with doxycycline and steroids, we could see the resolving retinitis in the right eye and resolved cotton wool spots in the left eye. So to conclude, whenever we come across a case of infective retinitis, it's most often its infective cause unless proved otherwise. Newer diagnostics such as polymerase chain reaction allow us to find out the exact cause of the retinitis. Most of them can cause decreased vision, can have devastating long-term effects if it's associated with necrotizing retinitis. CMV retinitis and progressive outer retinal necrosis occurs in immunocompromised individuals, whereas we do see CMV retinitis in immunocompetent individuals as well, like Dr. Neeraj presented. The prognosis is poor despite early intervention and appropriate management if the lesion involves the posterior pole. However, aggressive appropriate therapy can help to preserve the vision. One more thing I would like to tell, whenever we see a patients with ARN, you treat them with treatment within 4 to 6 weeks, the retinitis lesions will heal. But we should not stop. We have to continue for 12 to 4 weeks to prevent the other eye involvement. Otherwise, many months later, the ARN can occur in the other eye. Most of the times, induction therapy the patients will take. When it comes to the maintenance therapy, due to the cost factor, many of them will be reluctant to continue the treatment. We have to counsel the patient for the risk and also the cost benefit ratio. We need to analyze and individualize the treatment. So, thank you for your attention. I'll be happy to take up any questions.
I think it was a fantastic presentation, self-explanatory, lucid, and I don't think probably you will get any question. Fantastic, very nice.
Madam, he is Dr. BP Kashyap. He is the first vitreoretina surgeon of Jharkhand, and he is the organizing chairman of forthcoming midterm conference of AIOS in Ranchi.
Thank you, sir.
So, madam, we are very pleased, and we are very pleased also for the fact that our PGs got a faculty like you for the discussion. You will agree, Dr. Rahul?
Yes, ma'am, definitely,
Yes.
ma'am. The
Yes.
talk has been wonderful, ma'am, with lots of inputs coming to us, ma'am.
Yes.
Ma'am, I just
Yes.
like to just one query from my side, ma'am. How often do we often do we go ahead with PCR, ma'am, for our retinitis?
basically what happens, this necrotizing retinitis, ARN or CMV, we can make the clinical diagnosis. The more, especially if you have to put the drugs like valganciclovir, it is very expensive. Preferable to have the molecular diagnostics so that we are confirmed that we will know trial and error is involved. Whereas for ARN and other things, we can start it. Whereas CMV, it is useful, sir, to titrate.
This intravitreal cyclovir also works when the boy has given, they had given. So the intravitreal also works very nice, na?
Yes. Yes, this is molecular diagnostic. It is not freely available at all places. Affordability, accessibility is the question. If we can have, that is the best way to go. But if it is not there, then we go by the clinical judgment and treat the patient empirical basis.
Okay. Okay. Thank you, madam. So over to Dr. Vibhuti Bhushan, our vitreoretina surgeon from Jamshedpur, for and our ex-secretary, Jharkhand Ophthalmological Society, for vote of thanks, and above all, he is my batchmate also. MBBS days.
Thank you, Dr. Bharti, for organizing such a wonderful scientific program. And my special thanks to Dr. Padma Malini ma'am for a real master class. In fact, all the chairpersons also, we were also enlightened on many aspects, and we have learned a lot from your class. And a special thanks to you, ma'am, for taking time out and teaching us and all the PGs.
Yes.
After class. And I thank my fellow chairpersons also, BP Kashyap sir, who has been a guide for us in Jharkhand, Dr. Rahul, Dr. Harish, Dr. Abhishek, Dr. Divya, and Dr. Soumya, and all the PGs for taking keen interest. And this is a wonderful platform to learn from the masters, which our CSC, Dr. Bharti, is organizing. So I hope all the PGs show more enthusiasm, more interest, and learn from masters, because this is something that we didn't get. They have got the opportunity through virtual on a virtual platform, so they must take full advantage of such classes. Thank you once again, ma'am. Thanks.
Thank you, sir. Thank you, ma'am, for the wonderful initiative. It's a great session. Thank you.
Ma'am, we will invite you in future also, if we will be having some UVA case, and you have to come and bless the children with your great deep knowledge.
Thank you so much, ma'am.
Thank you.
My pleasure. Yeah. Thank you. Thank you, everyone. Thank you.
Thank you. Thank you.
So, Dr. Rahul Prasad, I will be needing your help, because I am not seeing, and Dr. Vibhuti Bhushan also, I am not seeing Dr. Poonam Singh. She is the coordinator of the fishbowl glaucoma. So now we are starting our Jhos.
Ma'am, I've joined.
Okay,
Ma'am,
okay.
I'm there.
Okay. Actually, you were not receiving my call, so I thought you are not there.
No, I'm here.
Okay. So over to Dr. Poonam Singh. She's a very senior glaucoma consultant in the Tata Main Hospital, Jamshedpur, and she will be introducing Dr. Sujata ma'am and Dr. Devendra. And first we will take up the talk of Dr. Sujata ma'am, because Dr. Devendra will join after him. Madam has a very beautiful presentation, case presentation, which she will show cases. And okay, over to Dr. Poonam for introduction of both the faculties.
Hi, Poonam.
Hi, good evening, sir.
And then after their introduction, please introduce the chairpersons of this session, and inner circle and outer circle.
Yeah, sure, ma'am.
Okay.
A very good evening, and we come towards the end of the session on glaucoma, which is a very important and very common topic also. So I would first like to introduce our first master for the glaucoma, Dr. Sujata V. Kadambi, and she is a senior consultant in glaucoma services at Shankar Nethralaya, Chennai. She has completed her graduate medical education from St. John Medical College, Bangalore, and was judged as the best outgoing student of her batch. So she's a master in ophthalmology from Arvind Eye Hospital, Madurai, and she has done a fellowship in glaucoma from Narayana Nethralaya, Bangalore. She is a member and of the Associate Advisory Board for Young Ophthalmologists, Asia Pacific Glaucoma Society. She is also the recipient of Ruby Banik Award for Best Clinical Research in Shankar Nethralaya for the year 2022. She has several publications in peer-reviewed journals and has worked on glaucoma patient education projects. Area of interest include work on intraocular pressure and imaging in glaucoma. We are very delighted to have you today here with us, ma'am, so that our PG students are also will be benefited by your presence and your talk today. A very warm welcome to you in this session, ma'am. Doc, and the next master speaker today is Dr. Devendra Maheshwari. I have met him because I was there for fellowship in Trinelveli for short glaucoma fellowship. So he's at present an associate professor and ma'am. Still, he's in Tirunelveli Arvind Eye Hospital. He has done his long-term glaucoma fellowship from there itself. He's done his glaucoma fellowship from Bascom Palmer Eye Institute in Miami, USA. He has done his observership at various top universities like Long Eye Center, University of Michigan, Ann Arbor, Wilmer Eye Institute, John Hopkins University, Baltimore, and the New York Eye and Ear Infirmary of Mount Sinai. So he's a speaker of various national and international conferences. We have heard him many times, and he's a very good teacher also. More than 85 publications are there in national and international journals. Various chapters also he has written in various books, and he is presently associated with a number of national and international studies and research work which are still ongoing also. He was awarded as best glaucoma paper award in ASCRS, AIOS, GSI, all the conferences for that matter, TNOA conference in 2022 and 2023. He invented the first indigenously developed cost-effective mixed device, which is also named after his name, Dave Dual Hook. So he's a member of various societies. He's a reviewer of various journals, and he is the person with whom you can associate for many publications also. So won WGO and ARVO Travel Grant Award was awarded to him. His areas of interest are MIGS, which is the in thing now in glaucoma in Asian population, especially in angle closure glaucoma, along with emerging goniotomy procedures. So very warm welcome, sir, to this session. We have been hearing you again and again for various topics at various levels. So very warm welcome. We are very much sure that our students will definitely be very much enlightened by your talk today.
So please first introduce the inner circle and outer circle because we are taking the presentation of the postgraduate student first, and she is Pooja Tanwar from Bhagwan Mahavir Manipal Hospital. So please introduce the inner circle and outer circle and the chairpersons of the masterclass also. Chairpersons of masterclass also.
Okay, ma'am. The present Dr. Inner circle persons are Dr. Samiksha, who is from RI RIMS, Ranchi, Dr. MD Nasir Khan, RIO RIMS, Dr. Swati Kumari, RIO RIMS, Dr. Shweta Kumari, Mins from RIO RIMS. Then there is Dr. Amar Kumar from MGM Medical College, Dr. Mayank Sharan and Dr. Vikas Thakur. They are all from MGM Medical College, Jamshedpur. And Dr. Bhavya, Dr. Raksha, Dr. Richa, and Dr. Sana Afreen, they are from our hospital in Tata Main Hospital, Jamshedpur. Dr. Lalita Priya Ji is from Gandhinagar Hospital, CCL Ranchi, and Dr. Nupur Gupta, Dr. Tushar Dhiman, and Dr. are from Bokaro General Hospital, and Dr. Ankit Pratik is from Kashyap Memorial Eye Hospital, Ranchi. And in outer circle, we have Dr. Anamika Chaudhary, who is from RIO RIMS, Dr. Vatsala Kumar, RIO RIMS, and Dr. Nidhi Sharma from MGM Medical College, Jamshedpur. Dr. Anamika Thakur, Bokaro General Hospital, Dr. Ujjwal, Bokaro General Hospital, Dr. Gagandeep Singh Gulati, Kashyap Memorial Eye Hospital, Dr. Shubham Singh, Kashyap Memorial Eye Hospital, Ranchi, and Dr. Ishad Khan, Kashyap Memorial Eye Hospital, and Dr. Pragya Chauhan, both from the same Kashyap Memorial Eye Hospital, Ranchi. So the presentation of the PGs is by Dr. Pooja Tawar. The topic is bilateral pressure diversion, a case of marked interocular IOP asymmetry post trabeculectomy. The time allotted is 5 minutes. So let's start with her talk.
Pooja, are you there? Pooja? Dr. Pooja? प्रेमलता पूजा से बात कराओ. Premlata? Ma'am, should we take the master class otherwise? Yes. So, sir. पूजा तो आई नहीं. Yes, so take the master class first. So the chairpersons for this session are Dr. BP Kashyap, who needs no introduction. Already, like we have discussed it many times. Still, he is the organizing chairman of the forthcoming AIS midterm conference in Ranchi. He is the past president Jhos and ex member committee of AIS. Dr. Deepak Lakra, who is professor of ophthalmology in RIO RIMS. Dr. Dharmender Kumar is the glaucoma specialist in Dhanbad Medical College and Hospital. Dr. Nitin Dhira, who is the chairman scientific committee of ISOC, and myself, Dr. Poonam Singh, who I am working with Tata Main Hospital in Jamshedpur. Dr. Anindya Anuradha is the head of eye department of Bhagwan Mahavir Manipal Hospital, Ranchi. Dr. Atma Prakash is the secretary of Dhanbad Ophthalmic Society. Dr. Shiril Sandeep Samaya is senior resident at RIU RIMS, and Dr. Amrita Srijan is the senior resident of RIU RIMS. So with all this, we finally go to the talk by Dr. Devendra Maheshwari on the redefined GAT. Sir, over to you, please.
So you are muted, sir. So you are muted. Please unmute.
Yes, sir. So thank you, Varti Madam and Poonam for kind introduction. And can you see my slide, please?
Yes, we can see. Yes.
Right. Thank you. So good evening all. Today we are living in the era of the MIGS, really transforms the management of the glaucoma surgery. So right now we look for the GAT. GAT is the most efficacious surgery. I think I will talk a little. Can you see my slide still?
Yes, we can see.
Yeah. So we look for the MIGS broadly divided into the base of the device-based MIGS. Really, they are really expensive, but the availability is again question mark, especially in country like India. They are the Gen implant, Hydrus micro stent, and eye stent. Though the eye stent and micro stent available in India, coming to the TM-based MIGS, that's called the GAT, Bang, Tanito micro hook, and my own hook, Devdol hook. They are readily available in very economic MIGS. So these are how the glaucoma surgery developed over a period of time. We're not going into details. So coming to how the timeline and MIGS evolution in India. So the glucose, the one company really who is really responsible bringing the MIGS in India, and later on the Dr. Venkatesh, he is my mentor from the Arvinda Hospital, Pondicherry. Really, he bring the GAT into the India in 2017 to 18. In between, Dr. Grover come with the inventor of the GAT. They come to Pondicherry and teach us the GAT, and later on the GAT really become very prevalent in India and really one of the most efficacious MIGs in India nowadays. Later on the 1918 KDB, Bang and Hydrus, and we have launched own new instrument very economic in the 2026. So always look about the India when you talk about the MIGs, really the cost is the biggest factor because we are the 75% of the population can't afford the stent-based MIGs. So you can look really the Bang, DDH, and the GET. Really, they are the more cost-effective MIG surgeries. Look here the impact of the GET. If you look for the worldwide, there's more than 30 countries are practicing the GET. If you look for the really big scientific, you look for the science. So look this over period of time 2014 to 2026 initial period, you see the number of publications. When the number of publication coming, something that surgery is good or surgery is more efficacious. So what is the GET? So GET is the surgery in which the conjunctive procedure in which thus we cannulate the canal 360-degree by using the either catheter or by using the fibroproline. It is discovered by the Dr. Devendra S. Grover. So these are the gentlemen who is behind this surgery, Dr. Grover and Folman. And I'm fortunate to have learned with them. So coming to that GET, really GET, I previously told, GET can be done by using the microcatheter. Really, it is very costly, though it has a illuminated light. You can see the light all 360-degree. But again, this is a country like India, and the low socioeconomic country, the catheter is costing the $500. It's difficult to afford. So the Grover come with the idea with using the same procedure by using the fibroproline that we talk in subsequent slides. So coming to the indication, really GATT has been originally designed for the mild to moderate POAG and selected case of the POAG cases, but by the use of the various country and by the practice of the various surgeons who are expert in MIGs, really it can be considered even the complicated cases like juvenile glaucoma, pigmentary glaucoma, pseudoexpansion glaucoma, even some of the people can use in the angle glaucoma also. So there are three pillars of surgical process, how to do the surgery. That should be the right patient selection, right instrumentation, and right surgical technique. So I will come one by one. So the patient selection is very, very important. There should be patient neck mobility. There should be no head tremor. Patient should be cooperative and really angle visible in the clinic. And these are the various instrument is required, but I will summarize you really what we need extra for doing the GET direct gonio lens and low temperature cautery, fibroproline. Rest of the things you can adjust, or we need the micro tying forceps that we can use the retinal forceps with the max thread forceps, or this a micro forceps what we used for this especially pupilloplasty, that forceps also can be used. The most important for any MIG study, the patient bed should be a bird, so the head should be above the heart. That will help to avoid the reflex bleeding. Then any MIG procedure, how we should do, we have to tilt the microscope 30-degree toward ourselves, 30 to 40 degree, and patient head should be go away from patient head should go away from you 30 to 40. Unfortunately, the video is not working. So main concept is there. Your scope should tilt towards you 30 to 40 degree, and patient head should go away from you 30 to 40 degree. And these are the lens, these are the requirement we need. Swan Jacob lens, then really we need the high density viscoelastic and fibroproline suture. So how to hold the lens after putting the high density viscoelastic into the cornea? You have to place the lens. You can use any lens like Catina or Prismasex. This is the Swan Jacob gonio lens. This is called the docking of the lens. Then only you can view the angle, and this is very, very important. When you see the angle, there should be the in-fast view. So mean you can see the three-dimensional structure of the angle. Then you can perform the surgery in much better way. So now coming to the what the steps of the surgery, how we to do it with most of the time with the phacoemulsification. So complete your phacoemulsification of the suture. So this is a 5-proline suture, so measuring the length, and this will make a kink, so you have an idea how much suture has been passed. And after that, low temperature cautery has been used to blunt the tip. I can again repeat you here. So this is a low temperature cautery, has the blunt the tip. So after blunting the tip, there is marginal this help of the MBR blade, you do the goniotomy first. After doing the goniotomy, the suture has been passed through the side port into the goniotomy side, and only 20 to 25 strokes are required to complete the 360-degree goniotomy. Once it comes, just you have to pull it off. Once you pull it up, you get the 360-degree goniotomy you can complete. And after the completion of the goniotomy, there may be some of the bleeding, so you have to leave some of the viscoelastic into the anterior chamber and keep your anterior chamber very tight and firm. So these are the steps of the GAT surgery. So again, I am showing the some of the example. Then this GAT, especially during the primary open angle glaucoma, after completion of the phacoemulsification, we did the goniotomy. After doing the goniotomy, simply the way show you the last surgery, simple way, we have passed the suture 360-degree, and the suture had been pulled, distally pulled, and complete the 360-degree goniotomy. Similar way, the GAT can be done even the PSEG cases. Sometimes we need to do the goniosynecholalysis to visualize the angle. Then once we see the angle, we have to do the goniotomy, and the suture has been threaded to the 360-degree canal. And really, this is some of the cases well proven in the GOG cases, and some of the cases really very challenging cases like this where we can't see the angle. You can see, but I strongly recommend you have to be very, very expert in POG. Then you venture in such difficult cases, especially in PSEG. So I'll be doing this first of the doing the synecholalysis. I'm doing the goniosynecholalysis, then making the neck. After once we got the neck, then we pass the suture. So it's not necessary in PSEG cases. You can once the suture, we are trying to pass the suture. You can see this is a PI, and really in such cases not necessary. You can able to pass in the 360-degree. Even you doing the 180 to 270-degree. It works well in certain situation. So the people really who is young novice surgeon, they want to learn the GAT. So the detailed video is available on the ISO video. So here we talk about how to do the GAT, what the precaution you have to take, how to start the baby step for learning the GAT. And look for the literature, so I don't waste much time because I think it's too late. So we look up the literature, we saw the 30 to 40% of IP reduction and significant reduction of the medication and effective in moderate to advanced glaucoma. So these are the various, the meta-analysis shows that the GAT is the most efficacious MIGS in compared to any other MIGS. So this is the right now every time we even talk about the GAT, people ask the long term. Really, this is a new surgery in terms of long term follow up. So we have 4.5 year follow up, longest follow up, and we see there's a 40% of IP reduction, and this is significant amount the IP reduction. Then come to India, when talk about the GAT and MIGS, people ask you, what do you, these are Caucasian people with the foreign articles are the what's their own experience. So really we have our own experience. We published the outcome of GAT in the Indian population, where we did in a phaco GAT in one arm and phaco plain GAT in other arm, and really both arm are doing well. Then we go ahead further, we shown that there's a good efficacy in the Indian juvenile open angle glaucoma patient also. So these are some of the other articles where we see in the challenging cases also GAT works well. And then recently this upcoming publication here, we proved this fibrinoprolin GAT, it works well in compared to POEG versus PSEG. If you look for here, really this works is results are comparable, and we compare this again the Tanito microhook and the GAT. Really we see this both are almost have the similar efficacy. So I think this is the last video I want to show you. This is the PSEG case. Here we do the goniosynecholalysis. After doing the goniosynecholalysis, the goniotomy is done by MBR blade. You can go with the 26 gauge needle also. And this is a similar way we measure the suture. After measuring the suture, tip is blunted, and the suture, fibroprolin suture, has been passed through the goniotomy. It needs 20 to 25 strokes to come from the distal end. Once the distal end come, just try to pull it off, and you can get the 360-degree goniotomy. So this is I'm talking about this publication. So GAT is equally efficacious between the POEG versus PSEG, and not only our study, there's a various other study are there, but they're the very early literature. There are only 4 or 5 studies there. They're showing the pace. GAT has shown the good promising outcome in the PACG. Apart from that, Dr. Sikha also published that the GAT have the very good outcome in the congenital glaucoma, and this is a really 10-year-old child. When I did the 10 days old child, when I did the trap plus trap, but somehow I find that my cornea is clear. So other I did the GAT in the 10-day-old child, and really they right now it is a 2.5 month follow-up, and really the childs are doing good, and these results are comparable between the trap plus step eye in compared to the GAT eye. So this the here the typical atypical angle really have to master in the GAT, then only you can venture in some of the complicated or really little difficult cases. So we are able to do here get into the 10-day-old child. So these are some complex cases. Here we can also do the GAT, but I will strongly recommend be master and get in the POAG, then only venture on the other. So like any other surgery, there are some of the complication, and hypema is the biggest challenge in the GAT surgery. They have the microhypema and macrohypema, so you have to take care of it. You have to leave your chamber very tight with using the 25% to 30% filled with the high density viscoelastic to avoid these complications. So the GAT has a really shows the very good efficacy, good safety profile as the economically efficient and versatile procedure. So just I will talk the 30-second more. Really, the GAT is really clinically good result, but really have the steep learning curve. To overcome these results, you can start with the like procedure like a bang, KDB, or again the bang has the own drawbacks, like they have the fused and there's a little it's too sharp, and the KDB is very costly. So for that reason, we come with the new instrument. It's called the Dave dual hook. Advantage there really is a streamlined surgical process. It's very economic MIS, not very much costly. It's single-handed. You can complete the bidirectional goniotomy. So just I will show you one video only. This is the Dave dual hook. It is the cutting is from the both side. So this is the PACG case. You can see here I'm doing the spatula to do the goniosynovial. After doing the goniosynovial, Dave dual has been introduced into the Slams canal. Once you go to the canal, just to glide it. Once you complete the other side, just remove from the other side. So this really instrument is similar to the Awarsinski chopper. So really muscle memory is there, and really is very easy to do even with the very novice, and it has been proved in the ACE OCT also. So thank you for patience listening. Any question, most welcome.
Thank you so much, sir. You make it sound so easy, but we all know that it is really the in thing. But it's definitely your last slide shows that it has a steep learning curve. But we everywhere this is the thing which is being talked about glaucoma recently. So, ma'am, Bharti ma'am, should we go for the next talk and then we'll take the questions together?
Take madam's, Dr. Sujata madam's talk, and then the Sakshi Tanwar will present. She thought that her presentation is tomorrow. So first madam's talk, and please Dr. Devendra, please stay connected, and I will request both the glaucoma faculties to stay connected after their talk because of the fishbowl PG presentation.
Sure.
Okay. Okay. So our next talk is by Dr. Sujata ma'am, and the topic which seems to be very easier, which is very difficult in the sense because that is the most confusing part, which will make easier the normal tension glaucoma, the diagnosis and management. So over to you, ma'am.
Thank you. Thanks, Dr. Bharti and Jharkhand Ophthalmological Society for this opportunity. Are you able to see my slides?
Yes, we can see, ma'am.
Instead of a didactic lecture, I prefer to have a few case-based scenarios, and I'll walk you through the diagnosis and management of normal tension glaucoma. I request the residents to please interact during the talk. Normal tension glaucoma is typical glaucomatous optic neuropathy with corresponding visual field changes and open angles in a setting of statistically normal IOP, which is IOP less than 21. So how do we arrive at this magical number 21? It is basically just the mean plus or minus 2 standard deviations of the population mean. But we know this concept is flawed because IOP is not normally distributed, but skewed towards higher values. The pathophysiology of normal tension glaucoma is little unclear and little complex, where it is multifactorial with IOP independent factors playing a larger role. Impaired blood flow, reduced resistance of the optic nerve head, vascular dysregulation, and systemic hypotension are all postulated and thought to be contributory to normal tension glaucoma. The disease prevalence in various studies varies from 24% to 32%. It is more common in the elderly with female preponderance. There are subtle differences between normal tension glaucoma and primary open angle glaucoma. In normal tension glaucoma, we can have a narrower neuroretinal rim for a given amount of visual field loss. The nerve fiber layer defects are more localized and closer to fixation. There could be acquired pits of the optic nerve, and disc hemorrhages are more common, about 2 to 5 times more common in normal tension glaucoma as compared to primary open angle glaucoma. Even the visual field defects which we get in normal tension glaucoma are more closer to fixation, deeper, and more focal. These patients tend to have nocturnal dip in blood pressures, elevated diastolic pressures. It may be associated with obstructive sleep apnea or vasospastic phenomena like Raynaud's disease. This is my first case. It's of a 67-year-old male, diabetic and hypertensive. The intraocular pressure on non-contact tonometry is found to be 14 and 17. Anterior segment exam is unremarkable. The fundus shows this damage like this. I hope the residents can appreciate the inferior notch, the superior notch and the nerve fiber layer defect, the nerve fiber layer defect in the left eye and inferior notch. So if you find a patient like this coming to your clinic, what are the investigations you would ask and how would you approach this patient? Maybe one of the residents from the outer circle can try. So my question is, you have this information with you. You have the NCT IOP of the patient, anterior segment exam with Van Herrig's grade 4, and you see that there is glaucomatous disc damage and corresponding visual field changes. So how would you take the investigations forward if this patient comes to your clinic?
Good evening, ma'am. Firstly, we'll talk about the 5 R's. That is the scleral rim, the neuroretinal rim, the RNFL, the peripapillary changes, and the retinal hemorrhages around the disc. And as far as the other finding is concerned, the VFA. Could you change the slide, ma'am? We'll after seeing the patient details and reliability index and false positive and false negative, which would be 13% and 33%. We'll go to the GHT, that is the glaucoma hemifield test, which shows the that it is outside normal limit. Then we would see the mean deviation. Since mean deviation is there are 3 criteria, mild, moderate, and severe. So mild is mean deviation less than -6, moderate is -6 to -12, and severe is more than -12. In this case, the mean deviation is -10. So it comes to be moderate glaucoma, and the pattern standard deviation, the CPSD, is checked, and the total deviation and pattern deviation are also seen. And because after following the Anderson criteria, we'd come to the conclusion.
Okay, thanks, Dr. Vatsala. So you are right. So this is the information provided to you, and NCT IOP, Van Herrig's grading, you're finding disc damage and the corresponding visual field changes like how you correctly described, and it is fulfilling the Anderson's criteria. What I wanted to highlight is, for a diagnosis of glaucoma, just NCT IOP is not sufficient. Okay, and for diagnosis and managing a patient with glaucoma, we all know the gold standard measurement would be by Goldman applanation tonometry. So even this NCT has shown pressures of 14 and 17, something in the normal range. So before we initiate treatment for glaucoma, we need to do a day diurnal variation test or an office DVT, that is from 8 a.m. to 5 p.m. Every 2 hours, you will take intraocular pressure measurements so that you have a good baseline to know what is the actual peak IOP of the patient and if the patient is having a lot of intraocular pressure fluctuations. Also, we need to document what is the central corneal thickness or the pachymetry of the patient. And most importantly, here I've only projected the information of Van Herrick's. Van Herrick's grade 4, it's not sufficient. No glaucoma exam is complete, or even a comprehensive eye exam is incomplete without doing gonioscopy. So you need to do gonioscopy to rule out occludable angles, to rule out any subtle pseudo-exfoliation. As I told you, normal tension glaucoma, you'll find the angles to be open angles. And also a very important fact for all of us to remember is gonioscopy is not to be performed only at the time of initial diagnosis of the patient. We need to repeat the gonioscopy periodically because as age increases, lens thickness can increase. So the angles can get narrower. And whenever a patient has unexplained progression, you need to revisit the diagnosis and repeat the gonioscopy to recheck whether you label the patient correctly as open angle or normal tension glaucoma. So normal tension glaucoma, remember, is a diagnosis of exclusion. So these are some of the salient features you need to elicit in the history. You need to rule out secondary causes of one-time damage to the optic nerve head and other systemic associations which I described. Okay, so this is another case in front of you. It's a 72-year-old male with a right eye normal tension glaucoma, advanced disc damage and visual fields progressing in the right eye, and the patient is on one medication, a prostaglandin analog in the right eye. Since the patient is already on treatment and the visual fields are progressing, the next step for you to logically think is to see if the patient is having a lot of intraocular pressure fluctuations. If that one clinic IOP visit is IOP reading is not picking up the peak IOP, so you're subjecting the patient to a day DVT and you find it in 10 to 12 millimeters range, which is kind of an acceptable range. The patient also had ischemic heart disease and was post angioplasty with stenting and benign prostatic hypertrophy and selective alpha-1 antagonist. Retrospective history taking, the patient gave a diagnosis of sick sinus syndrome. So in this case, we subjected the patient to further cardiac evaluation. Because of his sick sinus syndrome, we subjected him to an ambulatory Holter monitoring, and it was found that at one point in the night, the heart rate dropped to 37 beats per minute. And ambulatory BP monitoring for this patient showed that he used to have a nocturnal dip or blood pressure also dropping in the middle of the night. Carotid Doppler showed a 20% stenosis in the external carotid artery. So this 20% stenosis may not be considered hemodynamically significant by the cardiologist, but considering that this patient has advanced disc damage, normal tension glaucoma, has other cardiovascular morbidities, and is progressing, we need to communicate the importance of this finding to the cardiologist, and they would probably consider starting the patient on antiplatelets and following up and repeating even the carotid Doppler more periodically. So this is a third case in front of you. It's a 72-year-old male, normal tension glaucoma, advanced disc damage in both eyes on 3 medications, and visual fields are progressing. Again, the first thing we want to rule out is whether it is because of an IOP factor. Day diurnal variation shows that it is between 10 and 11, quite kind of acceptable. Basic cardiac evaluation, the ECG, echo, carotid Doppler doesn't show anything abnormal. The patient also gives a history of snoring. Considering this history of snoring, we subjected the patient to an overnight sleep study and found that the patient had an apnea-hypopnea index of 33:2, which is severe obstructive sleep apnea. So in this case, it was not the intraocular pressure which was caused the worsening of the glaucoma, but the associated obstructive sleep apnea, which is also associated with impaired blood flow to the optic nerve head. So this patient improved with weight loss measures, sleep hygiene, and a CPAP therapy. This is case 4. So you have a patient like this, 56-year-old male, day DVT in the range 12 to 14. Elsewhere, he's been started on 1 glaucoma medication. The disc looks like this and the visual fields look like this. Can any one of the residents from the inner circle describe the disc for me? Or anyone from the outer circle as well? It's open to the house. Can you describe the disc and you tell me if the disc and the visual fields are correlating and what would be your next approach? What other investigation you would ask?
Anamika.
Well, ma'am, the disc findings does not match with the RNFL. I mean the VFA.
And that's lovely, yes.
Yeah, it could be a disorder in the visual pathway. So we'll go with the MRI also to see whether there is a tumor or something.
Excellent, excellent. So what are those? So this, Dr. Vatsala pointed out correctly. So here you see it is more of like, say, I would describe that this is 0.7 with sloping rims, pallor more than cupping. Okay. And here the visual field defects respect the vertical meridian. So these are mimickers of normal tension glaucoma. So in what are those conditions when your patient walks into your OPD treated elsewhere as glaucoma? When would you consider to do neuroimaging? When the patient is young, they have new onset symptoms, pallor is more than cupping, it's very highly asymmetric cupping, the disc and the visual field defects don't corroborate, visual field defects are respecting the vertical meridian, and there's sudden rapid progression. Glaucoma is a very slowly progressive disease. So whenever there is a rapid deterioration in the patient in terms of the visual field, you have to go back, look again at the fundus exam. Have you missed any vein occlusion, or think in terms, neurological terms? Okay, very good, Dr. Vatsala. This is another patient in front of us. It's a 67-year-old female, normal tension glaucoma on prostaglandin analog. Previously, this patient has had very stable visual fields, and suddenly you have this kind of clinical picture. So what is this feature you see in this clinical picture, and what would be your next course of action? Can anyone else from the outer circle try?
Ma'am, there's a splinter hemorrhage there. So this is a splinter hemorrhage in case of a normotensive glaucoma has high chance of getting converted to a primary open angle glaucoma.
You're partially right. Okay, it is a sphincter hemorrhage, splinter hemorrhage. It's also known as a Dran's hemorrhage. These hemorrhages are associated with worsening. So in this case, what are the things you would think of? You will think if the patient is worsening, you want to look for any IOP fluctuations. So you will document a day office DVT or a day diurnal variation test.
Yes,
it could also be because of blood pressure fluctuations. So you will ask the patient to go back to their physician and monitor the blood pressure at multiple times of day, because that can also vary with activity and time of the day. You will document a stereo disc picture like this for you to follow up the patient in the future, apart from the basic visual field test. And although this patient has been stable, probably you were following up this patient at 6-monthly intervals or an annual checkup. Now, if everything else is normal in your this evaluation which you have done, you will consider following up the patient more closely, maybe in 3 months' time itself.
3 months.
Okay.
Yes, ma'am.
So it's important to remember that in IOP reduction in cases of normal tension glaucoma, we prefer prostaglandin analogs because that helps to blunt the diurnal IOP fluctuations better. We will avoid beta blockers because that can cause a nocturnal dip in the blood pressure. Alpha agonists are a second line. They also have a postulated neuroprotective effect. We could then consider carbonic anhydrase inhibitors, which have a postulated, they cause improvement in the ocular blood flow. Also important to identify and treat any cardiovascular disorder. We will consider surgery in case there is progression of the visual fields despite all other factors investigated is being taken care of and that is under control, because it is finally surgery which helps blunt diurnal fluctuations best. And when we consider trabeculectomy in these eyes, we prefer to use low dose mitomycin, multiple releasable sutures, so that we can titrate the eye pressures post-op. And it's also extremely important to take precautions to avoid hypotony. Okay. So this is another case in front of us. This is a 73-year-old male, normal tension glaucoma, showing rapid progression. You can appreciate this on the GPA, which I put on the right-hand side, okay, on 3 medications. Post-trabeculectomy, the left-hand side GPA shows that the visual fields have all stabilized well post-trabeculectomy. So the take-home message is normal tension glaucoma is a continuum of open-angle glaucoma. Here, the non-IOP dependent factors or the vascular factors play a greater role. Always confirm the diagnosis with a gold standard Goldman applanation tonometry IOP reading. Do a diurnal phasing. One IOP, you cannot label a patient as glaucoma, and before initiating treatment, it's best to establish what is the peak IOP, what is the IOP fluctuations. Always do a gonioscopy. Repeat the gonioscopy periodically. Exclude secondary causes or causes which can cause a one-time optic nerve head damage like trauma, like massive blood loss, long-term steroid use. Do refer to a physician for cardiac evaluation, nocturnal hypotension, or sleep apnea as and when applicable. Prostaglandin analogs are preferred. Avoid beta blockers. And when trabeculectomy is needed, take precautions to avoid hypotony. Thank you all. I'm happy to take questions if there are any.
Ma'am, should we go to the next class, class which was there, or should we go with the questions?
Dr. Pooja? Dr. Pooja, are you here? Yes.
Yes, ma'am.
Please share your screen.
Ma'am, is my screen visible?
Yes, it's visible.
Okay, ma'am. Good evening, everyone. My name is Dr. Pooja Davar, DNB first year resident in ophthalmology department of Bhagwan Mahavir Manipal Hospital. My today's case is bilateral pressure divergence, a case of marked interocular IOP post-trabeculectomy. The guide for my today's case is Dr. Anindya Anuradha. This is the clinical background for my case. A 65 years old male came to IOPD with complaints of pain, discomfort, and diminution of vision in both eyes, right eye more than left eye 3 months ago. Present visual acuity is no light perception in right eye and 6/18 and N36 in the left eye, improving to 6/12 and N18 with correction. He was diagnosed as a case of bilateral advanced glaucoma with uncontrolled IOP despite maximum medical therapy. Past surgical history: as per patient, he has history of multiple ocular surgeries in both eyes, including vitreoretinal surgery and trabeculectomy surgery in left eye, although previous records and timelines are not available. Past medical history: patient is using all 5 classes of anti-glaucoma medication in both eyes with a history of intolerance to oral acetazolamide. Systemic history: no combs are present. Addiction and family history were nil as per patient. In view of uncontrolled intraocular pressure, despite the maximum tolerated medical therapy, the patient was counseled regarding the need of intervention. For the right eye, trabeculectomy with mitomycin C was offered as treatment options, while retrabeculectomy with mitomycin C was advised for the left eye. After discussing the risk, benefit, and expected outcome of the available procedures, the patient elected for trabeculectomy with mitomycin C in right eye, and trabeculectomy was performed after obtaining informed consent. A trabeculectomy was subsequently performed in the left eye 1 week later. Now, this is the status post-operatively. This is the clinical presentation. The 65-year male presented in OPD for post-op follow-up after bilateral trabeculectomy with mitomycin C. The patient reported marked relief, pre-operative ocular pain and discomfort following surgery. The visual acuity was stable and maintained as the pre-operative status, which was nil perception of light in right eye, and best corrected vision 6/12 and 18 in left eye. Post-operative examination revealed markedly divergent intraocular pressure between the two eyes. Now, this was the fundus photo of both eyes, as we had no any documentation of the previous surgeries. But for the right eye, we can see the media is very hazy and the disc is hardly visible or barely visible. And we can see some scar, which is probably looking like a previous old cryo scar. For the left eye, I can see it's a very highly tessellated fundus. And if I focus or I describe the optic disc, I can see the CDR cup disc ratio is almost around 0.9, which is near total cup with peripapillary atrophy. And if I can see, there's some few old laser marks also, which describes the past surgical or laser intervention. Now, this is the post-operative examination for right eye and the left eye. Eyelids were hyperpigmented in both eyes. Lashes, the hypertrichosis was noted. Conjunctiva, the superior filtering bleb were present for both of the eyes post-trabeculectomy. Cornea for right eye, descending membrane folds were noted, while in the left eye, cornea was clear. Anterior chamber was normal and of normal depth and quiet for both eyes. Iris, surgical peripheral iridectomy noted. While in the left eye, there were the two surgical peripheral iridectomy showing or giving the evidence of the trabeculectomy done 2 times in the left eye. Pupil was mid-dilated, fixed and non-reactive to light, which is as the same status as pre-operatively. While for the left eye, it was round, regular and reactive. RAPD was absent in both eyes. Lens status, it was aphakic in the right eye, and there's a PCIOL in bag in the left eye. IOP was taken by the applanation tonometry, which was 3 in right eye post-operatively, while it was 30 in left eye. Now, these are the pictures of the both eyes. As we can see, the gross appearance of the right eye. It is showing, the picture is showing the hypertrichosis, as the cornea is hazy, and it's showing the mild DM folds also there. Now, if I look just below the picture, I can see the bleb of the right eye. The bleb, it was diffused, elevated, and thin-walled and reduced vascularity. The leak, the proof of leak was not there, as during the CDL test, it was negative. If I'll go for the left eye, I can see the cornea is comparatively clear to the right eye, and there is a there's the surgical peripheral iridectomy is also visible. If I see the bleb of the left eye, it is diffused. Diffused, elevated, but marked vascular bleb, well formed, and no signs of leak were present, as CDL tests were negative in left bleb too. Now, the post-operative course for the right eye. The persistent post-operative hypotony with intraocular pressure ranging between 2 to 8 mm mercury during the follow-up period was noted. It was bleb description is given already. Diffused, elevated, thin-walled, superior in position, filtering bleb with reduced vascularity. CDL was negative. To see the cause of hypotony, B scan was performed, and it revealed the choroidal detachment. Management in view of the nil visual prognosis, systemic corticosteroids were deferred. The patient was managed conservatively with intensive topical steroid therapy, initially administered hourly for a week and subsequently tapered to every 2 hourly. At present, he is using topical steroid 6 times daily in right eye. The close follow-up is maintained for monitoring the status of eye. Now for left eye, the post-operative course is, it is the persistent post-operative IOP elevation, which was in range of the 22 to 29 mm Hg. Repeated immediate IOP reduction on following intervention were noted. For example, digital massage. On following, regular close follow-ups, it was seeing that the IOP was high as in range of 22 to 29, but it post digital massage, it was immediately in the range of 10 or 11. Same as for the Hoskin pressure response, it was there and suture lysis were performed in different settings. If I'll describe the bleb of left eye, it was diffused, low height, vascularized, superior under-filtering bleb. No evidence of bleb leak was there. Management, in view of the persistent IOP elevation, even after doing the intervention, the reinitiation of anti-glaucoma was started. The anti-glaucoma started with the Bimet T, which include the bimetoprost and timolol, 1 drop daily. Bleb needling was performed only after reinitiation of the anti-glaucoma, and IOP was not achieved. IOP was ideal. Desired IOP was not achieved. Now patient is maintaining IOP in range of the 10 to 12 mmHg, and close follow-up monitoring is there for seeing the IOP.
Thank you, Dr. Pooja. And after intense scientific sessions, we are somewhat between highly enlightened and slightly exhausted. So I would request Inner Circle residents to quickly ask your questions to Dr. Pooja. Do we have Dr. Lalita, Dr. Nupur? Anyone who wants to put up question to Dr. Pooja? Dr. Vatsala, you would like to ask something?
Yes, ma'am. Dr. Pooja, I have just 2 questions. The first one is a comment actually. You said that you used all the 5 medications, anti-glaucoma medications, but according to the treatment trial of glaucoma medications, you can use at least, you use one. If it is not accurate, then you maybe combine 2 and then probably a third one, or then switch to a surgery or laser or whatever. You used 5. So what was it judicious to use 5?
Actually, okay, ma'am. Thank you, ma'am, for the question. Actually, ma'am, patient was presented to us while he was already using the all 5 classes of glaucoma. So he came to us with this status, and I put it in as a history of the medical therapy, which was giving evidence towards the maximum medical therapy failure.
Okay, and the next question I would ask is, how would you differentiate? How in a patient with marked post-trabeculectomy IOP asymmetry, how would you determine whether it was because of the bleb dysfunction or the outflow resistance, or distal to the bleb there was some problem, or was it because of the steroid response?
Ma'am, ma'am, to differentiate it, that ma'am, we have to first of all, we examine the bleb. Actually, if bleb is over filtering, ma'am, it will be the appearance of over filtering bleb will be different. It will be highly elevated, thin wall, and ma'am, it will be hanging margin showing that it's a hyper filtering bleb. And ma'am, if there is a which we see that usually immediately after the surgery, due to the high inflammation in a patient, there can be a ciliary shutdown. Then because of that, it can also cause the hypotony. And then ma'am, third, ma'am, can I?
bleb, whether it's because of the bleb or the
Yes, ma'am.
or something, a pathology related distal to the bleb, or is it because of the steroid response?
Ma'am, steroid, I think, ma'am, steroid, according to as much as, ma'am, I have knowledge, I have no idea about, like, not so much idea about the effect of steroid on the, ma'am, this.
Thank you.
So anyone else would like to ask question, or we move on to the experts?
One question, which laser was used during laser suture lysis, and did you classify the bleb according to the Indiana classification system?
Yes, ma'am. For the bleb, ma'am, I classified the bleb according to Indiana classification. For if I'll, ma'am, classify the right eye bleb, it was, ma'am, height. It was height of H2, and then, ma'am, extension. It was diffusely according to clock arts. So, ma'am, extension was E2, and, ma'am, it was reduced vascularity. So it was V1, and then it was if I'll classify the CDL, there was no leakage, so it was S0. While for the left eye, ma'am, the classified accordingly. It was height was, ma'am, left kind of flat, so I classified it as the H1. Ma'am, it was same, the diffusely extended, so it was E3, and vascularity V2, and, ma'am, CDL was S0. For, ma'am, laser suture lysis, we use the ma'am, we use the red laser.
No, okay, it's okay. Thank you so much. Presented very nicely. Thank you so much, and answered also very nicely. The classification, you're very thorough with it. Thank you so much.
Thank you, Dr. Pooja and Dr. Anamika and Vatsala. So let's move on to the experts. Dr. Devendra Maheshwari, please give your expert comments for the presentation.
And we have cash prize for the best discussant. So you all have to select one discussant whom you like the best, because for each session we have kept cash prizes 1,000 for the best discussant. So for glaucoma also you have to select one person.
May I ask a question to Pooja?
Yes, sir.
Pooja,
yes,
you said there were multiple surgeries in both the eyes, right?
Yes, sir.
So do you have the detail of the surgeries?
No,
Was the
sir.
buckling was done, or the VR was done, or what surgeries were done?
Sir, actually, we have no documentation. It was as per the patient was the informant, and we could get some idea only via the seeing the fundus photo while doing the examination. As we seen in the fundus photo of the right eye, that there's an old cryo laser scar was there. So we were guessing the one of the surgery involved the cryo. And, ma'am, sir, same for the left eye, as we have seen that
When you examine the patient, you know whether the buckling was done or not. Number one.
Yes,
Number
sir.
two, you will know that whether the patient was injected for silicone oil or not, whether silicone was further removed or not. You will see
Yes,
all the scar marks there. It's so if the conjunctiva is scarred, so the trabeculamin is bound to fail, right? And number two, if there are somebody is giving so many drugs, anti-glaucoma medications, so you have to see what is the visual field analysis. What is the visual field that is left? It is a very tubular one. You don't jump to the trabeculectomy. You have to further increase the medication. If it's nothing is, well, of course, and the last you can go ahead with that.
Yes.
These are my comments.
Okay, sir.
Thank you so much, sir. Dr. Devendra Maheshwari, your inputs, please.
Pooja, nicely presented, extensive presentation. You covered everything. Just I
Thank
want
you,
to
sir.
know first what happened to your right eye. You tell what happened to left eye, but you don't mention what happened to your right eye.
Sir, right eye, sir, he is actually still maintaining the hypotony status in the range of 3 to now he is 3 to 8, and then, sir, the recent USG still showing the CD. So,
CD.
sir, actually it's we are focusing more on the left eye, as right eye is already sir negative PL negative, so we are trying to save the only eye that patient has. So we are still maintaining that IOP with these topical steroids only.
Okay, though they're nicely presented, but I say sometimes really we have to think about the surgery, which surgery has to be selected. So, in my opinion, really, it doesn't require the right eye to maintain, to jump into the surgery. Right eye, we can wait and watch, and you can use some kind of the cyclodestructive procedure, really in the right eye. And again, doing the trabeculectomy, especially in aphakic eye, where the previous multiple surgery has been done, really no PL. I think instead of doing the surgery into the right eye, you should more focus on to the left eye. Though the left eye you nicely presented, but I don't think by the way you presented the case is nicely presented. So probably you have the either tight suture and the patient is already on multiple medication. So more likely they have the chronic conjunctival inflammation, and there's an early sign of bleb failure is present in your case the way you
Yeah.
the highly vascularized bleb, but you difficult to understand, but I strongly believe it won't be very diffuse. I feel really this is subconjunctival scarring is more likely in the left eye, and that's why you are able to get the 10 to 12 mmHg after doing the suture lysis. And for suture lysis, really we use the green laser, not the red laser. We use the NDR, green laser. We use the green laser. Okay. And I think overall is good, but keep your finding. Don't go for just theory, what written theory that is not. See your case, really what is seen. You nice, you are theoretically you're very sound. You told the classification accurately, but you should match what the theory is, that you match your clinical findings. Okay.
Okay.
So,
Yes,
so your
sir.
clinical finding is not matching what the photograph you're showing. And maybe I may be wrong because I'm seeing the one dimensional, you're seeing a three dimensional, but I feel the bleb was flat in the left eye, probably the tight suture or subconjunctival fibrosis. So
Okay, sir.
my take-home message is there: better we can avoid the surgery in the right eye, but left eye you manage very nicely. It's good.
Thank you, sir.
I have one question. Will it be wise to start bimatoprost post-operatively post-trap patient?
Really, no. Really, usually in post-trabeculectomy cases, we should consider the either beta blocker or the carbonic anhydrase is the ideal choice. But it's fine. Sometimes the patient is already on the 5 anti-glaucoma medication. Really, we can't give all the 5 glasses already he is using. So really, if they think sometimes that some people, some of the newer thoughts are that they want to the maximum efficacy to the reduce the intraocular pressure. But I agree with you, Sweta. We should not jump into the prostaglandin analog, because again the PG analog going to cause the more inflammation and then increase the risk of the bleb failure.
I think in the right eye, if the pressure was so high, so in most of the time, what happens is if the pressure is very high, and the moment you enter the anterior chamber for trabeculectomy, there's sudden decrease of IOP, and then there's choroidal has to happen. If it doesn't happen, it's a surprise in such a very high IOP.
Yes, sir. So I feel really if you do this in reduce the IP, giving the mannitol, do the slow decompression, we can we can achieve the good trabeculectomy. But I feel really doing the right eye, doing the trabeculectomy, it not justified actually.
True.
Because no PLI, we can do some cyclodestructive procedure, focus on to the left eye, because probably that's the more seeing eye, as you mentioned previously, where to look for the visual field, look for how much visual field is remaining. So that has to be keep in focus, and really we have to intervene first into the left eye, save the first eye, the seeing eye. That should be the more in the focus.
Okay, sir, I have a question.
Sure.
Sir, my question is that as you said, sir, we can give this at mannitol too, but sir, that patient was complaining of constant pain due to the so much of high IOP and that discomfort. So sir, for example, if we give the mannitol to the patient, then it will decrease the IOP. But sir, if we have to give the mannitol by IV, so sir, will it be more painful for the patient to give mannitol every time that, sir, if IOP gets high?
Not every time. What he meant was just pre-op, so that the intermittent
Okay, sir.
down, and then go ahead.
Okay, sir. And then, sir, one more question, sir. If, like, sir, as the retrap was not should be done in the right eye. So, sir, what else I could have like approached surgically to give the comfort or relieve the patient from the pain and discomfort which was because of that, sir, so much of high IOP.
So really, in my scenario, really, I don't know the place where you're working, but my choice will be the diode cyclophotocoagulation DLCP
Okay.
we can do. That's the best choice such cases. And really,
Okay,
if
sir.
you have the more advanced center, some people can perform the micropulse also. Though there is a non-seeing eye, it's very costly procedure micropulse. So my best choice will be the DLCP in right eye.
Okay. Thank you, sir. Thank you, sir.
So, Dr.
Thank you
Pooja,
so
what
much. Yes, Dr. Sujata. Yes,
I
yes.
just wanted to propose a question for Dr. Pooja. So from the conversation which we have had now, what factors you will consider in a patient before choosing like the different treatment options which have been told, a cyclodestructive procedure versus a trabeculectomy versus a glaucoma drainage device? What are the things which you need to consider, like post multiple VR surgeries? What are the factors you will consider in the patient before, like, which is going to indicate I will choose cyclodestructive procedure for this patient or a trabeculectomy for this patient?
Ma'am, so before choosing a patient for any kind of intervention, as much, ma'am, I learned from this, I'll see that if patient has any surgical history, I'll see if that patient is on a complete maximum medical management therapy. I will see if there is any visual prognosis. As I said, that if it is already PL negative, there was no need to do the retrap. And then I'll see the expected outcomes, as Kashyap sir said that if there was already so much of IOP, when I was trying or we were trying to do the surgery, we were causing more harm by causing the CD and during intraop than doing the benefits. So I'll look up to all of these factors pre-operatively, and then I'll choose my patient wisely for the respective intervention.
True, correct. So the vision is important. So whatever we do must be beneficial for the patient. So if the patient has a very, very poor vision potential, we would tend towards cyclodestructive procedures rather than an invasive procedure. Second is look at the lens status, whether the patient is aphakic or pseudophakic. In this case, doing trabeculectomy when there is aphakia, it's a vitrectomized eye and it's a single compartment eye. So the aqueous flows in all directions, not just in the stoma and into the bleb. So and there are more of inflow of inflammatory mediators. So the chances of scarring, fibrosis, hypotony is all common. So what you saw is kind of expected in this case. Okay.
Yes.
Third important thing is to look for conjunctival mobility. Whether the patient has had a previous belt buckle, this subconjunctival silicone oil. How will you test for conjunctival mobility at the slit lamp?
Ma'am, conjunctiva is mobile, so ma'am, in slit lamp I can ask the patient to
you will just put a drop of topical anesthetic,
yes,
use the cotton tip applicator, and see
then
the conjunctival is mobile. That's a prerequisite for doing a trabeculectomy or a glaucoma drainage device. So now in your left eye, already when trabeculectomy is done, and it's already post multiple VR surgeries. So probably a glaucoma drainage device may be an option to be considered than a retrabeculectomy. Okay. So because it's already post multiple surgeries, the conjunctival scarring is going to be extensive. The chances of fibrosis is going to be more, and you already one trabeculectomy has failed. Okay. So
yes,
that again, whatever you saw on the left eye is kind of an expected outcome. So a glaucoma drainage device may be a better option. Okay.
Okay, ma'am. Thank you.
Thank you, experts, and thank you, Pooja. And I must acknowledge that a great presenter is one who learns from the discussion, and you have clearly demonstrated that how thoughtfully you incorporated the insights given by the experts during the just now discussion. Thank you, Dr. Pooja, and I would like the experts to tell whom to give the best discussant winner for this session.
Because
Dr. Vatsala,
yes.
Dr. Vatsala or Dr. Chaudhary or
Ananya Chaudhary or itself Dr.
Anamika.
Pooja, Anamika Chaudhary or Dr. Pooja itself, because she herself was asking the
Pooja,
questions.
Pooja. It goes to Pooja.
I think
Pooja,
Pooja deserve
yes.
it.
So wonderful. This is the great thing that the presenter herself becomes a discussant. Very good, Pooja.
Good.
Wonderful.
So you
That's
need
too
to
unanimous. That's too unanimous.
Yes,
My God.
there is a CME on third
Yes,
or
ma'am.
fourth.
Being a first year resident, she answered really very well. Very well. Being a
Thank
first year
you.
resident, it was really a great achievement for her to answer so nicely and all the deep
Yes.
in depth.
And Dr. Anamika, can you tell me the date of the CME? Is it third or fourth? Do you remember? The
Where, ma'am?
Rakshya Ophthalmic Forum CME, because on that day in the CME itself, there will be distribution of the cash prizes. So Pooja also has to come. She can contact Premlata, my secretary, because I will be going to IIRSI Chennai for the conference. So Pooja, you talk to Premlata and you be present in the CME, because in CME time only there will be a award distribution of the cash prize to Dr. Amar, Dr. Anamika, Dr. Neha, and to you.
Okay.
Very nice. The presenter itself became a winner first time.
Well done.
Well done. And now over to Dr. Nitin Dhira for vote of thanks. Nitin Dhira is the CSC, IZOC, and he is the director of the Sharda Eye Hospital, is a glaucoma person, and cataract and glaucoma, and from Jamshedpur. So over to Nitin Dhira for vote of thanks. First time you came to our fishbowl session, you saw the inner circle, outer circle, the discussions. How did you feel?
It was it was a very fantastic program. Thank you, madam. Thank you, Dr. Sweta Walia, madam. And thank you, Dr. Sujata. Thank you, Dr. Devendra Maheshwari, for giving a very insightful talk. And moreover, I would like to say thanks to all the discussants. Those were very actively participating, and madam had made the presentation so well, and she was keep on asking question, because the questions were on the basic sides, and I was very happy to see that the residents were discussing. It was a very nice program. I appreciate. So thank you everyone for joining this session. Thank you, madam, for
So
including
thank
me.
you everyone, actually, and thank you Dr. VP Kashyap sir also, because he stayed till end, because everyone today supported me for one session or the two session, but nobody supported me throughout for all the 8 sessions. It is only my husband Dr. VP Kashyap supported me. So I am
मैडम आप
really
हमें भी भूल
thankful.
गए मैडम हमें ही भूल गए आप हमें
अरे
भी भूल
Shweta
गए
Walia,
Sweta madam ka
you are the moderator. You are the
she was
moderator.
there.
I know you are awake from 5 a.m., but you are a moderator. He is just a chairperson, and he's not a chairperson in all the session. Still, he remained with us. We are the moderators. We have to be present. It is our session.
Well, then she
So-
had taken her, and she was very active in all the sessions.
Yeah, I know, and she texted me that she has become CSC of two big societies. Madhya Pradesh is such a big state, and she is our Women Ophthalmologist Society India chairman person scientific committee from this year. So she is having 2 portfolios and very big portfolios.
But I
And
must
then-
tell you, all the specialist speakers were superb. They were the
Yes.
bosses, and they are so bubbling with the knowledge. Oh my God, fantastic people.
And I will
Thank you
really
so much, guys.
appreciate
Thank you so much.
these girls, the Anamika and Vatsala. They are till end taking participation in every discussion. Anamika and Vatsala, they actually
you, ma'am.
deserve a special prize from Kashyap sir.
Thank you, ma'am.
स्पेशल प्राइज तुम लोग दोनों बहुत अच्छे हो दोनों इस लास्ट तक रहे एंड फिश बोल एंजॉय अगर कोई किया है तो सबसे ज्यादा अनामिका एंड वत्सला
Yes, ma'am.
It's
Actually,
very informative, ma'am.
and it is fun also because we keep on being interested what's coming next, what questions gonna be asked, how can I improve myself by the presentations.
I know. So Anamika and Vatsala will be having special prizes from Kashyap sir.
Thank you.
And Anamika will be getting 2 prizes, one in the cornea and another will be the special prize.
Thank you, ma'am. It was very we collected a lot of questions that will be asked to us in our final exams
Yes,
also.
yes.
In the Viva sessions.
Yes. You are very brilliant.
Thank
Very
you.
brilliant. Both the girls.
Thank you.
Both the girls are gem. Okay,
Thank
thank you everyone. Thank you Nitin
Thanks
Dira
to
because he
everyone.
also came very late. And this is the session is very at the fag end of the day. So thank you all. Thank you so
Thank you, ma'am.
much. Thank you.
Thank you.
We have session tomorrow also. So
Thank you.
tomorrow you
Thank you,
all have to
everyone.
come.
Good night,
Tomorrow
madam. Good
also.
night.
Tomorrow कल भी प्राइज लूट के ले जाना है तुम लोग दोनों को. Tomorrow there are 3 sessions. 3 sessions. 2
And
LDP.
we will have a dinner break also. Give a break for dinner, yeah.
Yes. Okay, thank you. Bye. Bye everyone. Bye.
Bye.
Bye.